Hello to everyone. Welcome. Good morning, good afternoon, good evening, maybe good night. This will be our second International Ocular Proton Therapy Symposium. We have a nice program of a lot of speakers and just some reminders before we start. Well, please mute yourself. The meeting will be recorded. And some general information. We have one program path, no parallel sessions. The symposium is divided in principle into 3 sessions, introduced by an expert of this field, followed by 16 contributions from 3 continents and 8 countries. The allocated time per presentation is 8 minutes sharp. The speaker himself is sharing the screen, and there will be discussion, this means question and answers, at the end of each sessions. So you can raise your questions either using the chat at any time. We will record the questions and the chair of the session will read it to the audience, or use the raise hand function during the Q&A and wait for the moderator to give you the point. After each session, we have a 3-minute break to get a little bit relaxed or to get some food or something to drink. And most important, which is new this time, there's one prize for the best presentation, which is voted by the audience at the end of the meeting and will look like this. So just a short glance on the program. So we're starting with the program, which is now have then our imaging and diagnosis and treatment planning session itself. Then we have something about positioning and facility upgrade. Then it's the online voting and the awarding of the award and the end of the symposium at around, well, 21:40, or you see the additional times they are plotted. So if you want to have a more detailed view on the program, there is, well, if you have a more detailed view on the program, please look at the website, you see it above. And well, it's not me alone who did all the work, but I had a great group of colleagues, friends who helped out, and this is our symposium's working group. And with this, I would like to thank you. We have over, well, 180 registered participants, maybe now it's nearly to 100. And I will hand over to Saini from Washington University to just start with the first session. And I wish you a nice day and a good symposium. Jay, it's yours.
Thank you, Jens. Welcome, everyone. We'll, in the first segment, so this symposium is divided into 3 segments. The first segment is focusing on the imaging. The title of the first talk, which is the introductory talk for 15 minutes, the title of the first talk is Imaging in Ocular Proton Therapy, is presented by Dr. Jan-Willem Beenakker. Dr. Beenakker is an associate professor of ophthalmology, radiology, and radiation oncology at the Leiden University Medical Center in the Netherlands. His research focuses on the development of new imaging techniques, including ocular MRI, and their application in ocular oncology and refractive surgery. Dr. Beenakker, over to you.
Thank you for your introduction. I'm happy to start this nice symposium. So I will talk on imaging, and we have research collaborations with these companies. So when you look at ocular proton therapy, it's quite different than many other forms of radiotherapy in terms of planning, where you have a CT, you delineate on the CT, maybe you make it a bit nicer with MR. When you look at ocular proton therapy, we have many different imaging modalities which we somehow try to combine to get a 3D model of the eye, and which we then do our planning on. And today I will quickly highlight the most important imaging modalities. I'll start with fundus photography, then with the surgical measurements, and then share a bit on ultrasound, CT, and MRI. Fundus photography, in a sense, I think is one of the most easy imaging modalities, in the sense that you just put a camera and a lens in front of the eye, and then you can see what's inside the eye. You can see the optic nerve, you can see the macula, you see blood vessels, and you also see this pigmented mass. So it's a very easy and very powerful imaging modality, but also because it's so straightforward, there are many different types of imaging of fundus photography. And I will share some of the different types which are used in ocular oncology. So the first, I think, distinction between the flavors is whether you have a contact camera. So there's nothing between the camera and the eye. So you see that here, that's probably done during surgery. So there's a liquid between the camera and the eye, and you have non-contact cameras, which are nowadays used more and more. The advantage of a contact camera is that you can have a much wider field of the retina compared to a contact camera. So compared to a non-contact camera. So with a non-contact camera, you have about 30-40 degrees of view, whereas with the contact cameras, you can have up to 100 degrees. But of course, it's a much more invasive procedure. So there are some cons and pros there. Then you have the classical camera, which is a normal camera, but nowadays there are also many different types of scanning of laser ophthalmoscope. So they use a laser, sometimes different types of colors of laser, and then based on the reflection, you can also make a picture of the inside of the retina. These give a so-called pseudo color image. So the colors you see on the image reflect the different types of laser, but not necessarily the color what you would get when you would yourself look into the eye. These scanning laser ophthalmoscopes can go to very large angles. Sometimes they have a field of view of about 200 degrees. So you can almost see the complete retina with these scanning laser ophthalmoscopes. Then, particularly for diagnosis, there are also fluorescence kind of imaging techniques like fluorescence angiography, where you administer a contrast agent and you see which part of the lesion is well perfused, which can also help you in delineating the lesion. And at least the last one I want to show today is ocular coherence tomography. It allows you to make a cross-section of all the different layers of the retina. So for example, you can see the retinal detachment very clearly here. And one of the big advantages of this modality is that you can measure distances between the macula, which you see here, and the optic nerve. So many different types of optical methods to evaluate the inside of the eye, mainly used by ophthalmologists for differential diagnosis. But in terms of ocular radiotherapy planning, I think the big advantages of these techniques is that they also allow you to visualize very flat structures, such as the macula, which I think is not visible in all the other types of modalities we'll see later today, but also flat extensions of the tumor. A big limitation of the optical techniques is that you also always take a picture through the optical elements of the eye. And these elements differ from patient to patient. And so Force et al. Recently showed that between a mildly myopic and mildly hyperopic, so a bit longer and a bit shorter eye, there can be about to 30% difference in scaling of these pictures. So if you want to make an accurate length measurement, you really need to take the scaling or the optics of the eye into account because it complements or it adds up to the optics of your camera. When you look at the imaging modalities which take a larger view of the retina, for example, the Optos scanning laser ophthalmoscope, there have been reports which show that the mapping from the 3D retinal shape to the 2D fundus image differs between cameras, but even within a camera, it has been shown that this can be result in inconsistent distortion. So this is something you really need to calibrate probably if you want to use it for treatment planning. The other type of measurements which we of course use are measurements during the clip surgery. So clips are put on the outside of the eye, and during the surgery, a light source is put in front of the eye, and then on the outside you can see the shadow cast by the tumor, which nicely resembles its location. During the surgery, you can of course measure the clip tumor distances, but also the size of the lesion, and it's of course also very useful for detecting an extraocular component. Although I think as a surgeon, you would be very happy if you already know it before the surgery, if there's something outside of the eye. The limitations of these surgical measurements are on the one hand that depending on the location of the lesion, the surrounding can be an accurate measurement. So if there's, for example, if there's a muscle insertion at the location you want to do a measurement, it can be less accurate. But also if the lesion is very posterior of the eye, it can be difficult to get a good measurement because the surrounding anatomy is preventing you from getting a good view. Also, when the lesion is very anterior of the eye, it can cast a shadow behind itself, and this can erroneously be included as a lesion when you do the clip measurements. And also when there is hemorrhagic retinal detachment, this can also be very difficult to differentiate from the lesion during the surgical measurements. Ultrasound is a big complementary tool compared to other previous tools because they only allow you to visualize the outside of the lesion, whereas the ultrasound gives you depth information. And it also allows to evaluate structures behind the eye, for example, to screen for extraocular extensions. In ophthalmology, or at least in ocular oncology, there are two types of probes used. Most commonly used one is a B-mode ultrasound. It's about a 220 megahertz probe, which you position on the opposite side of the eye that if you want to visualize. So if I want to visualize this part of the eye, I go from there, and then you take a cross section through the eye, and then you see the lesion here. There's very good contrast between the lesion and the vitreous, but if you want to see the extraocular structures, the contrast is relatively poor. If you want to look at a lesion which is on the front side of the eye, typically a UBM probe is used, which has a higher frequency of 50 megahertz, and it therefore has a higher resolution, better contrast, but its penetration depth is more limited. And this probe is put directly on the side of the eye where you want to take the image. For posterior UV melanoma, the ultrasound has a very good observer variation of about 0.3 millimeters, so it's quite good, and also has good agreement with other imaging modalities. For tumors in the front of the eye, so the ones which you use with the image with this probe with a higher frequency, there the limitations are a bit bigger. First of all, this probe has a limited field of view, so sometimes not the complete lesion can be visualized, so then you see more variation between observers, and also the correct positioning of the probe can be more problematic, and therefore you see a larger variation between operators. Then when we look at CT imaging, compared to ultrasound, it has a big advantage that it's a volumetric visualization of the tumor, the eye, and the surrounding anatomy, so you can really look at the location of the tumor in 3 dimensions, and this is not only visible then to the ophthalmologist, but also, for example, to the radiation oncologist who's doing the planning. CT, however, has a very low soft tissue contrast, so differentiating between tumor and sclera, for example, can be very difficult. And also the tantalum markers produce very large artifacts on CT images. But I saw that later today there will be a talk on a different material for these markers, so maybe that will be a good solution so that CT images are a bit more useful for ocular proton therapy planning. And finally, MRI. It's a relatively new imaging modality, at least in ocular oncology. But nowadays there are protocols for multiple vendors which allow you for high resolution images of the eye and surrounding structures. And a recent study showed that MRI is more reliable for detecting extraocular components of the tumor, but also, for example, invasion of the optic nerve. Because the MRI has a very high soft tissue contrast, you can really accurately use it for 3-dimensional delineation of your tumor. And studies show that both in terms of geometrical accuracy, but also in terms of inter-observer variation, these delineations, these are sub-millimeter accurate. So that's a good promise for future MR-based treatment planning. A big limitation of MR is that you cannot see very flat tumor components, and you can also not see the macula on the MR images. Sometimes you see a thickening of the choroid, but then it can be very difficult to differentiate this, whether this is a choroidal inflammation or whether there is a flat tumor component. And I think that's a bit the story of all the imaging modalities which we currently can use. They all have their own strengths, but they all also have their own limitations. And I think in the end, it's very important to really combine the knowledge of the different modalities to really come to the most accurate treatment planning. And in that sense, I think we're very happy here in Leiden that we have this multidisciplinary setup where we, together with the ophthalmologists, look at both the ophthalmic data and the radiological data to really get the most accurate model of the tumor and surrounding structures. And with this, I really want to thank all my clinical colleagues, so our PhD students, and I also want to still invite you for the upcoming deadline for the next ocular oncology group meeting in Europe, which will have a dedicated radiotherapy session.
Thank you. Thank you so much. Yeah, I think we have a time for a lot of questions. So any questions from the group? I don't see anything in the chat. I could ask a question. So in terms of a tumor volume, the size, which modality closely resembles the actual size? Like how do different modalities compare, like CT versus ultrasound versus MRI?
I think the tricky thing with the ultrasound is that you only get one cross-section. Maybe your ophthalmologist can get 2 cross-sections, but it's a relatively limited visualization of the tumor. So in that sense, I think MR is better because you can delineate the tumor in 3D. With ultrasound, of course, you also have a 3D visualization, but the slice thickness is a relatively limiting factor. These tumors are yeah, I think you have about 0.6 millimeter if you're a very good CT. So it's still relatively coarse compared to the tumor size we're looking at. On the other hand, with current ocular proton therapy, you have the geometrical models. I think the very small details, for example, such a mushroom shape, will not really directly impact your treatment planning, but maybe for staging, the volume will be better on MR.
Thank you. Any other questions? A note in the chat. So you can either ask questions by raising your hand, or you can ask question by typing in the chat window. All right. Well, let's thank Dr. Beenakker for his talk. Thank you. And let's move on to the next speaker. Next speaker, the title of the next talk is Changes in Tumor Volume Before and During Ocular Proton Beam Therapy. The talk is presented by Lisa Klaassen. Miss Klaassen is a PhD candidate at the Leiden University Medical Center. Her research focuses on using MRI in treatment planning for ocular PT. Lisa, over to you.
Yes, thank you for the introduction. Indeed, today I'll be talking about changes in tumor volume before and during ocular proton beam therapy. This study was funded by Varian, and we also received research support from Philips. All right, from previous research, we know that generally uveal melanoma is a slow-growing tumor, and therefore it's generally assumed that tumors do not change or do not change much during the treatment process. So in between diagnosis and the end of treatment, there's not too much tumor growth. And also, if we look at the current results that are obtained with the current ocular proton beam therapy workflows, this seems the case. However, these are obtained with the current margins of 2 to 3 millimeters. And if we want to move towards a more conformal and possibly clipless treatment, potential changes in tumor volume and shape do become more relevant. Furthermore, this may be especially important if there is some time between imaging and therapy, for example, if the therapy is performed in a different hospital. Therefore, the aim of this study was to determine whether tumor volume of uveal melanoma changes before and during proton beam therapy. And today I will discuss 2 time intervals, the first being the week of treatment, as the treatment is given in 4 daily fractions. And also the time interval from the imaging that's used for the treatment planning until the end of treatment. For this purpose, we included 14 patients diagnosed with uveal melanoma at the Leiden University Medical Center, who were treated with proton beam therapy at Holland PTC in Delft. These patients had a mean tumor prominence of 7 millimeters, ranging from 3.5 to 12 millimeters at diagnosis. We analyzed 3 MRI scans for these patients. The first was performed after the clip placement surgery. This was called the planning MRI. Then we did another MRI for this study, which was performed 5 days before the start of treatment, and then another one at the day of the final fraction. We delineated the tumors on the 3D contrast-enhanced T1 weighted image. And we use this sequence because on this sequence it is easiest to distinguish the tumor from associated retinal detachment and blood. But both the T1 before contrast and the T2 weighted scans were available as a reference. In this image, you can see an example of the delineation. So they were done in 3D. The yellow contour is the tumor contour, and then at the white arrow over there, it's the tantalum clip artifact. These scans were obtained with an acquisition resolution of about 0.8 millimeters isotropically, and with a scan time of about 2 minutes. From the contours, we obtained the tumor volume. However, because the tumor volume is generally not used as an input for the current treatment planning systems, we also looked at the prominence and the clip tumor distances. All right, moving on to the results. In this graph, you can see the relative change in tumor volume on the vertical axis and then the time on the horizontal axis. So first we'll look at the interval from the planning MRI to the day of the final fraction. For most patients, this interval was either 16 or 23 days. And in this time period, we observed a mean increase of 8% in tumor volume. You can see in this graph here that for most patients, the tumor volume increased, whereas for one patient, there was a decrease in tumor volume. And I'll have some more images on that on the next slide. For the interval during treatment, the changes were way smaller. Right, here I have some examples of what the scans look like for these patients. So this is a patient with an 8% increase in tumor volume, with the planning MRI on the left, with the green contour, and then the MRI after the final fraction on the right with the pink contour. And in this image, you can appreciate the difference between these two contours, which is also shown in the prominence, in which we observed a 0.9 millimeter increase. This was the patient who showed a decrease in tumor volume, which can also be observed in the contours, which was also seen in the prominence. We discussed this case with the ophthalmologist and radiologist involved for this patient. And the hypothesis is that this difference in tumor volume is caused by an intratumoral hemorrhage that is present at the first time points and then is slowly resorbed. Right, so we also looked at the tumor prominence, in which we observed an average increase of 0.4 millimeters. And this change was larger than 0.5 millimeter for 6 out of 14 patients. We observed here that if the tumor volume increased, the prominence generally also increased. So it's the same patients each time. Also for the clipped tumor distances, on average, there was not a large change in the clipped tumor distances, although some variation was observed. And for the patient with an increased tumor volume, we saw a decreased clipped tumor distance and the other way around. So that was quite what we expected for this measurement. Right, moving on to the conclusion. During proton beam therapy itself, uveal melanomas show a minimal change in tumor volume. However, between the imaging that's performed for the treatment planning and the end of treatment, volume changes larger than 10% were observed in half of this patient cohort. We do think, looking at the good results in terms of local control, that the current margins adequately address these changes in tumor volume. But if we want to move towards more conformal treatments or change the workflow in other ways, we think it's important to keep the time interval between imaging and treatment as brief as possible. And we think that clipless treatments may contribute to a decreased time between imaging and treatment. I'd like to thank everybody involved in this work. And also thank you for your attention. I'd be happy to take any questions.
Thank you, Lisa. There are a few questions in the chat. This question is from Alejandro Mahal. Tendence okay, but average value of prominence changes from 0.4 millimeter as a resolution of 0.8 millimeter. Alejandro, are you there? Could you ask that question? Sorry.
Yes, I'm here. I was wondering that we can see the tendency, and that is a very interesting fact. But the values that you are giving are in the order of 0.4 millimeters. Sorry. The values are close to 0.4 millimeters, but the resolution of the system is 0.8. So can you hear me? Yeah, so I'm wondering about the value of these absolute measurements.
Okay, I think the question was the acquisition resolution is 0.8 millimeters. How can we draw any conclusions about measurements smaller than that? Is that correct?
I may repeat, but I don't want to take all the time. I think that the tendency that you are showing is a very interesting one. I think that there are many factors, image acquisition and these kind of things, but I'm worried about the quantification. Difference in the prominence of 0.4 millimeters when the resolution of the system is 0.8.
Yeah, I understand your concern. It is true the acquisition resolution was 0.8 millimeters. We then do an reconstruction resolution of about 0.3 to 0.4 millimeters. So that's more in the range of the difference we observe. But we do think, as we see a trend in these images, and it's not all centered around 0, that is, yeah, it's not just noise that we're seeing.
Thank you.
There are more questions in the chat. Next question is, did you correlate the changes seen on MRI to changes on repeat fundus images?
Well, we do have fundus images from diagnosis, but we did not repeat the fundus images at each time point where the MR scans were made.
Another question from the chat. How frequent is the imaging required during PT based on your data? Could you?
Well, of course, the orthogonal KV imaging is done every day, but for different purposes. I think one scan for treatment planning should be enough if the time interval between that scan and the start of treatment doesn't get too large.
I have a question. So based on your data, it looked like most patients saw an increase in size, right? There was maybe only one patient. So maybe there could be some kind of a recipe, average increase, and that could be maybe addressed in the margins.
That could be interesting to look at, yes. Yeah.
All right. Well, thank you, Lisa. I guess we can move on to the next talk. The title of the next talk is Radiographic Evaluation of the Carbon-Coated Ceramic Fiducial Marker for Treatment Simulation, Planning, and Setup of Ocular Proton Therapy on a Dedicated Beam Line by Dr. Alexei Trofimov. Dr. Trofimov is the lead physicist in the Ocular Melanoma Service at MGH. He has supervised over 1,000 eye treatments, either delivered through protons or iodine plaques. Dr. Trofimov, over to you.
And thank you very much, Dr. Saini, for this introduction and for reading this really long title. First of all, I would like to acknowledge my co-authors on this project, Tom Ruggieri and Jos Verburg. My only disclosure that I'm going to talk about a marker that I received free of charge for evaluation. So, of course, we're all familiar with the long and glorious story of the use of fiducial markers for ocular proton therapy, which actually started even before human treatment started back in the 1970s in animal experiments at Harvard's cyclotron, which were conducted by Dr. Constable and Dr. Gragudas. So here's a picture of the classic Gragudas ring, tantalum ring. It's about 2.5 millimeters in diameter. It has 2 eyelets. So this has been used for over 5,000 patient treatments here at Mass General and many more thousands around the world. So the way it's used is that in transillumination, the markers are usually placed close to the margin of the tumor. So, and this allows us to visualize the location of the tumor for setup, where there is no, otherwise there is no tissue contrast. So this works out really well for kind of traditional model-based planning, such as iPlan, where you can fit the eye model to this marker configuration and essentially determine the location of organs at risk and structures of interest with respect to the markers. The disadvantage, of course, is that the small markers produce very large artifacts on CT planning. And now that many of us are transitioning to CT-based, MR-based planning, it is worthwhile to consider something that reduces CT and MR artifacts. And of course, this is not the first time that alternatives have been proposed. So here's one example of a paper that was published by Dr. Daftari in 2018 when he proposed a titanium marker. So what I'm going to talk about is biomarker secure marker, which is commercially available and approved for treatments in the United States. It's available from carbonmed.com, located in Minneapolis, in St. Paul in Minnesota, United States. So the material used for this marker is zirconium oxide, ceramic, and it's coated with what is billed as biocompatible carbon layer. So here's the shape of this marker, kind of shaped like a barbell. The main difference compared to the tantalum ring is the shape, of course, and the distance between the eyelets. So this distance is 2.9 millimeters. In a classic tantalum ring, of course, the bridge is very small, so it can accommodate a very small suture, or rather a stitch. So for the carbon marker, you do require about 3 millimeter long stitch. So otherwise, so the size is different. As far as the area of impact is concerned, it's about the same for both markers. And the volume is about 3 times larger for the carbon marker, which is based on a higher thickness. As I mentioned, this has been approved for use in patients for over 10 years here in the United States. So this is definitely not the first time that this marker has been reported. So we have some reports for the use of stereotactic treatments. So you can see that these markers were touched with a single suture here. Also, this marker has been evaluated for proton therapy in the past by the group in Seattle, led by Dr. Saini. So they looked at cone beam CT imaging, CT artifacts, and also they investigated the dose perturbations caused by these markers. And finally, since last year, these markers have been used for proton treatments at Mayo Clinic in Minnesota. Not at MGH yet. So what we wanted to do at MGH is just evaluate these markers to see how well they could substitute our current tantalum rings. So we ran this quick, simple imaging end-to-end test using a very simple phantom. So this rubber ball shaped like an eye, 4 markers were attached to it. And the pattern was kind of replicating our standard patterns that we use for placing of tantalum rings at Mass General. So we have 4 different, or rather 3 different patterns. One I would call U pattern. This is used for large anterior tumors. And this basically marks 3 sides of the tumor. This can also be used for larger posterior tumors. Another pattern is O pattern, where the markers completely surround the tumor. And this is used for equatorial tumors. And lastly, for small posterior tumors, we use Y pattern. So we have 3 markers marking the margin of the tumor, and 1 is out for setup. So the next stage of the imaging test is to take radiographic simulation. We do it in 5 different gaze directions. So that was done for this, for the markers, and then the radiographs were imported and marked up in iPlan. So here's the U pattern, O pattern, and Y pattern. And of course, you can see that it's really easy to identify the eyelets, the shape of the marker. So this renders really well to this workflow. So based on the marked up radiographs, we create eye model. So we can do it with 4 markers. In this case, I marked up both ends of the marker. So essentially we have 8 reference points that we know are close to the surface of the tumor. So that's more than enough to define, to place the sphere in 3 dimensions. So of course, this can be done with fewer, with just 3 markers, and also with 2 markers, right? So when we compared the models created in this process, there was really no difference between going from down from 4 markers to 3 markers, but there were some differences we start seeing going from 3 to 2. So 2 markers might be a little bit of might produce a somewhat less stable model for the eye. So the next step is just to optimize treatment plan. So here's for the U marker, for the U pattern, we have anterior tumor. We optimize treatment plan, export the plan into our imaging system, and set up the phantom according to this plan. So here's 2 more examples. And just to show you kind of the accuracy of the model, yellow is the expected positions of the markers, and dark shadows are the actual markers. So as you can see, they can be placed really well within 0.5 millimeter easily, just kind of our standard setup expectation. So of course, this works really well for phantoms. I also tried to evaluate how it would be working in kind of more realistic situation. Here the markers were attached to a skull phantom. We can still see very good contrast. We also scanned the markers on or phantoms on our CT scanner. Just visually, biomark produces slightly smaller artifacts compared to tantalum ring. If we use a standard metal artifact reduction sequence, the size of the mark can be recovered pretty well, and compared to tantalum ring, which recovers the volume, the size about 5 times of the actual marker. And so this could also be imported to commercial treatment planning systems, so you can see the shapes can be recovered pretty well. And this is an example of digitally reconstructed radiographs. So lastly, I'm kind of out of time, so just very briefly say that some radiographic studies have been done by Dr. Saini a few years ago when he looked at those perturbations. So we replicated some of those studies, and I guess the main message is that there is perturbation posterior to both markers, but the size of it is about the same. And in this example, it was limited to just a few percent, under 10%. To summarize, the markers can be well resolved on X-rays. It's possible to digitize both islets or the center of the bar. The size between the islets, the distance, rather 2.9 millimeters, serves as a built-in scaling check in iPlan. And it's possible to reduce the number of markers to 3 from 4. There is a visible reduction of CT artifacts, and standards artifact reduction sequences can recover the true shape of the carbon marker. And lastly, there was limited dose shadowing that was observed that was similar to tantalum rings. So I'd like to thank a few people, and I will just leave this picture of possible placement patterns for 3 markers. Thank you very much.
Thank you, Dr. Trofimov. Any questions from the audience? I do not see anything in the chat window. Maybe one question. What do you think about the comfort for patient compared to this marker being like a lot bigger in size compared to the tantalum marker? Could you comment on that?
Yeah, as somebody who has some experience with brachytherapy, you can place much larger objects definitely in the eye. So this is thicker, about 4 times as thick as tantalum ring. It's a little bit longer. So you would expect this might cause larger discomfort, but we don't really have, at Mass General, we do not use these markers. They are used clinically at Mayo, Minnesota. As I understand, patients tolerate them well. It's not like there is no randomized study that was designed to say experience is different between these 2 markers. But definitely, there was a long history of the use of this marker in the clinic. Maybe not so long for proton therapy, but definitely, they've been FDA approved for over 10 years.
There's a question in the chat. Instead of dose shadowing, can you give the change in the range? So what kind of a range?
That is correct. Yeah. So there are 2 effects that we see there. One is, the effect of scatter, and another one is range pullback, right? So there are 2 different effects. If the marker is placed towards the end of a SOBP, you would see much larger effect from dose pullback, like from the range pullback, right? So I had a very superficial look at this. I just put some markers in the beam and took a few film measurements. Jay, you did a very thorough study with Monte Carlo, and of course, the effect depends on the orientation of marker, on where it is within this OPP. So in our practice, usually we only so if the marker is placed posterior to the tumor, there is no effect, right? It's like it's all it's outside of the CTV. If it's kind of tangential on the edge of the eye, there is also little effect because it's mostly concentrated in the sclera, right? So we're mostly concerned with markers that are placed anterior to the tumor. And usually there is enough at Mass General, we use enough distal margin, and we also use doses that might be somewhat higher, up to 70 gray, somewhat higher than many institutions use. So currently it's not a concern with tantalum rings. We've never had any complications kind of definitively linked to the positioning of rings. So I do not think it is a huge concern going forward with any new type of marker. And of course, as physicists, we're always concerned about dose discrepancy. Like 5% is a big discrepancy, right? It's a large hotspot or cold spot. But also, we have to take it in the context of how much more precise our treatments are because of these markers in the field, right? So we can set the patient up very precisely. We can also, in our case at Mass General, we also take confirmation X-rays at the end of treatment. So we need to have some markers present in the field. And that makes this treatment much more accurate in spite of any deficiency that may be caused by the dose shadowing.
Thank you. Thank you, Dr. Trofimov. Any other questions? I guess we can move on to the next talk. Before we move on to the next talk, I want to let audience know that the next presenters know that we had a cancellation of one talk. So if you run over from 8 minutes to more, it should be okay. Yeah. All right. The next talk the title is the Fringe Pattern Profilometry for Anterior Eye Segment Reconstruction in Ocular Proton Therapy, presented by Dr. Riccardo Via. Dr. Via is a biomedical engineer at PSI. His research is focused on imaging solutions for non-invasive patient positioning and target volume definition in ocular proton therapy. Dr. Via, over to you.
So thank you very much for the introduction. I hope you can hear me and see my screen. So treatment planning software such as iPlan models the eye with a generic geometrical model that is then fitted to anatomy of the patient. But in iPlan, this is based only on two quantitative measurements on a patient-specific basis. Specifically, the length of the eye is measured using ultrasound, and then the three-dimensional position of clips is measured using X-rays. And this makes, in the end, for a rather inaccurate eye model, and the discrepancies between the eye model generated with iPlan and the three-dimensional anatomy of the patient measured using imaging such as MRI and CT has been investigated in the past quite extensively, and the most discrepancies have been seen in the determination of the anterior eye segment, and that is particularly true in case of posteriorly located tumors with posteriorly located clips. However, in the last few years, there's been the introduction of several other options for treatment planning in ocular proton therapy that embeds the use of three-dimensional volumetric imaging while generating the eye model on a patient-specific basis, and this will for sure improve the accuracy of eye models. However, even these latest prototype and commercial products basically define the anterior eye segment for those prediction purposes using the concept of the skin plane. So the skin plane is a plane that's parallel to the beam direction, and basically everything that's beyond the skin plane is modeled as water, and everything that is prior to the skin plane is modeled as vacuum, and this is how those distribution is performed, those calculation is performed. And I couldn't find any sort of consistency among different centers on how you place the skin planes with respect to the anatomy of the patient. And however, this makes for a rather crude approximation of what actually is the situation in the treatment room. And the same is valid for the eyelid, the modeling of the eyelid, for those patients that have to be treated with the radiation passing through the eyelid. And however, in this case, there's a little bit more consensus over how to model the eyelid, and most centers adopt a 2.5 millimeter isotopic enlargement of the anterior eye segment to model the eyelid. But however, this is even a more crude approximation with respect to the skin planes, because this does not rely on any sort of patient-specific measurement. So the aim of this study was to find out whether high-resolution three-dimensional topography of the patient's surface using fringe pattern profilometry can be used to improve the anterior eye segment definition. And for this study, we have acquired data on 17 patients undergoing ocular proton therapy at our centers. 3 of them have been treated through the eyelid. And amongst the dataset, we have 93 concurrent measurement of the three-dimensional position of clips using radiographic imaging and a measurement of the eye anterior segment surface or the eyelid surface using fringe pattern profilometry. For the same patient, obviously, we have the eye plan treatment plan and the eye plan treatment model, as well as we acquired MRI images of those patients. So fringe pattern profilometry is a technique for surface reconstruction that is widely used, but however, the application in ophthalmology are quite limited. In our case, well, the techniques is a non-contact, non-invasive optical imaging techniques. And in our setup, we use 4 calibrated optical cameras and 2 fringe pattern projectors installed astride with respect to the beamline, with 2 cameras on the left side and 1 projector on the left side, 2 cameras on the right side and 1 projector on the right side, to image respectively the left eye and the right eye. This is a picture of the setup in the treatment room. So fringe pattern profilometry is based on the projection on the object surface of a fringe pattern and the analysis of the deformation of this fringe pattern as imaged by optical sensor, and the analysis is performed in the Fourier domain. The end result of this analysis is basically an estimation of the surface of the patients under observation, and maybe you can see it a little bit, even though it requires a little bit of imagination. You can see here, this is an image acquired on one of our patients. You can see here basically the eyebrow and the eyelid that's been retracted by using eyelid retractors. And here you can see the surface of the eye that's visible after eyelid retraction. And this basically makes for a measurement of the three-dimensional eye surface or the anterior eye segment surface in the geometry of the treatment room. To validate this measurement, we have compared them with the same measurement of the anterior eye segment using MRI imagings and contouring of these MRI images transformed into the geometry of the treatment room by using the radiographic, the clips, the radiographs of the clips as the geometrical reference. So as you can see here, basically the measurement of the anterior eye segment surface agrees quite nicely with the contouring performed over MRI. And when we compare quantitatively the discrepancies between the three-dimensional scans using fringe pattern profilometry and the anterior eye segment contour on MRI, we measured on average discrepancies that's lower than 0.46 millimeter. Here, I will show you an exemplary case on how this can work for a patient that's been treated for the eyelid. This is how a fringe pattern looks like when the patient is treated through the eyelid. And here, basically, is a representation of the eyelid measured in the treatment room, transformed into the geometry of our MRI sequences. And you can see here that our measurement of the eyelid actually seems to fit quite nicely the measurement of the eyelid performed using MRI. And when we compared this measurement of the eyelid with our definition of the skin plane for one specific patient, we have measured a discrepancy up to 2 millimeter, which could actually have some significant impact on our prediction of the dose distribution. So to conclude, it's an unassailable truth that volumetric imaging in treatment planning can improve and will improve the anatomical description of the anterior eye segment. However, even this newer treatment planning system still relies on the use of skin plane, which is quite a good approximation. We have demonstrated how fringe pattern profilometry can be used during ocular proton therapy treatments, and we can measure the patient surface with sub-millimeter accuracy. However, these techniques require further validation, especially in the case of the measurement of the eyelid surface. However, we still believe that the use of these techniques and having available three-dimensional topography of the patient surface measured in the treatment room can improve the accuracy of the dose prediction and introduce an anatomically accurate definition of the eyelid in treatment planning. And with that, I'd like to thank you for your attention.
Thank you, Dr. Via. Any questions? There's a question in the chat. Accuracy of the eyelid refractory positioning every day. It's by Alejandro Zal.
So we checked the position of the retractor using a beam eye view optical camera. So this is a camera that's fixed above the beamline, and through a mirror see the eye through the nozzle aperture. And so we checked that the eyelid is retracted according to the treatment plan specification using that camera. But in principle, yeah, one could think about using also these three-dimensional surface reconstruction techniques to do so.
Any other questions from the audience? Well, thank you, Dr. Via. Let's move on to the next talk of the session. The title is Optical Aberration Correction of Fundus Photographs for Ocular Proton Therapy Planning by Corné Haasjes from Leiden University Medical Center. Corné is a PhD student in the MRI group with a background in medical physics and a strong love for optical simulations.
Thank you for your, excuse me, I think I still need to share my screen. Thank you for your introduction. We receive research support from Philips Healthcare and from research labs. Funduscopy is commonly used for the diagnosis of uveal melanoma, and fundus images contain details that are not visible in other modalities. For example, the flat extensions of the tumor that are not visible in MR images. So it would be useful if we could fuse MR images and fundus images and then use the combined imaging data from both modalities for proton beam therapy planning. But there's a problem with those fundus images. They contain aberrations, and these aberrations are partly geometrical, caused by projecting a 3D ellipsoid surface onto a 2D plane. And this can be compared to geographic map projections. So just like in this map, the size of Greenland is exaggerated, the size of the tumor is also exaggerated in the fundus image on the slide. But on the other hand, there are also optical deformations, and these are caused by refraction of light rays by the cornea and the lens. This can be compared to a straw in a glass of water, which looks like it's broken, but we know it's not. Now, there are correction methods for this problem, or at least for the geometrical part, but these correction methods ignore the optical part. And as we have seen before today, recently published research by Pors et al. Has shown that the optical differences between patients result in quite significant differences in the magnification of fundus images. This is something you can actually try out yourself, as the method has been published online, so we invite you to take a look at this. But this observed significance brings us also to the aim of this study, which is to develop a method to map fundus images to MR images, incorporating the patient-specific optics and also the retinal shape. And in order to accomplish this goal, we performed optical ray tracing simulations on 27 subject-specific eye models, and these eye models have been based on the standard ophthalmic data of healthy volunteers. Optical ray tracing simulations are quite standard simulations used in refractive surgery. They're successfully applied over there. That's why we also applied them in our research. And we performed those simulations in Optic Studio and automated them using ZOSPy, which is an open source Python library for optical simulations in Optic Studio. And then it looks a bit like this, where you have your code in which you define your eye model. We adjust the shape and also the position of the cornea and the shape of the lens, and also personalize the shape and position of the retina. And then we calculate the path of the light rays through the entire eye model until they hit the retina. And then we take all those 27 ray tracing results for quite a few angles per result together, and we perform some analysis on them, to which we will come back later. So let's take a look at a typical ray tracing result. And in this analysis, we will look at these results in terms of angles. So first, we can characterize every ray in terms of an input or camera angle. And then we can also express the corresponding retinal location as a retinal angle. And this is a retinal angle calculated with respect to a reference point, and we can choose this reference point. So in this example, we use the center of the retina. And if you then look at the relation between the camera angle and the retinal angle, we see that it's a slightly non-linear relation, but also with a considerable variation between subjects. But we can also use a different reference point, for example, the location of the pupil. And as you can see, the relation is still slightly non-linear, but the variation between patients is much smaller. And then finally, we also use the second nodal point as a reference point, which is an optical characteristic of the eye. And in this case, you can see that the retinal angle and the camera angle are almost equal, and the variation between patients is even smaller. Also for very large angles, like 60 degrees is quite a large angle in terms of imaging. So this relation is, it's nice, it's useful because we can use it to create a mapping method to map fundus images to 3D images without using ray tracing. And we can do this using only standard ophthalmic data. And we compared the results of this mapping method to other available methods. And for this comparison, we'll start with a typical ray tracing result for a camera angle of 40 degrees. And this serves as our ground truth. And then we used different methods to calculate a retinal location for based on this camera angle. As you can see, we get different retinal locations. Some methods perform quite well, some don't perform that well. As you can see, the blue marker is right spot on. So the second nodal point method, at least for this angle, gives typically an accurate estimate of the retinal location. We also evaluated this for other angles in a range of 0 to 80 degrees. As you can see, the second nodal point method gives a very low systematic error and also a sub-millimeter random error over the full range of assessed angles. Other methods that do not incorporate the optics of the eye also perform quite well in terms of the systematic error, but the random error is larger. And finally, iPlan appears to have a rather large systematic error. Although in practice, this isn't that bad because we use clips also to register those images, so this mitigates quite a lot of these errors. But then still you need clips, and one of the nice properties of the second nodal point method is that we can incorporate it quite easily in ray ocular without using clips. So in ray ocular, we built an eye model based on MR data, and we delineated the tumor. You can see the contour here in green. And then we used the second nodal point method to scale our fundus image and load it into the fundus view of ray ocular. And as you can see, the MR-based tumor contour in green overlaps quite well with the tumor on the fundus image. The largest error is about 1 millimeter, so that's on the order of a single voxel in our MRI scan. And this is still due to some simplifications we made in our models. For example, in our simulations, we assumed an ideal camera. We know the ideal camera is, or we know the camera does have an effect, it's not ideal. We also only performed our simulations for non-contact cameras, although we did some simulations for contact cameras which yielded similar results. And stitching of fundus images also has an effect on deformation, so this is also something that still needs to be explored. So in conclusion, we can use the second nodal point to give an accurate mapping of 3D imaging to fundus images. And the next steps in our research will be a validation of this method on a larger cohort of patients, and also on different cameras to incorporate the deformations introduced by cameras, for which we would like you to participate in this validation. With this, I want to thank everybody who was involved in this research for their contribution. And also I want to thank you for your attention.
Thank you, Corné. There are questions in the chat. First question is, isn't this going to be patient specific and depends, for example, on thickness of cornea or thickness of lens? This technique. Question is by Jan Rabicek. Do you wanna maybe expand on the question, Jan?
Yes, this is going to be patient specific, and therefore we also used patient specific eye models, which were based on biometry, based on cornea topography. So we already incorporated the thickness of the cornea, the thickness of the lens, and all the other patient-specific optical parameters in our models. So this has been taken care of in our simulations.
Another question in the chat. The fundus image shown is a composite image of 3 single photographs. That's the question.
Yes, that's also the case. Stitching is one of the, well, it's a common method to get a wide field image using a normal 30-degree field camera. And in this case, the stitching was performed in a way that the central photo has not been deformed. So that's, in our opinion, that makes the stitching more accurate. But still, stitching is indeed something that we want to incorporate in our simulations and also, well, in our method as well, because this may introduce additional deformations.
Thank you. It looks like I missed a question. Thank you for Alejandro. It's a question by Martin Hansen. Which fundus projection method parameters were used in Ocular default or some other settings? And how WSA, the position of macula, was done? How was the position of macula performed?
For the fundus projection, we used the eye plane projection, so not the polar projections used by Octopus and also implemented in Ocular. And regarding the, and we customized some of the parameters. So in that way, we implemented our second nodal point method. Regarding the position of the macula, so in this case, we shifted the macula so it was in the center of the fundus view, and also based the position of the macula, or the distance of the macula, on the fundus photograph. The distance of the macula with respect to the optic disc was based on fundus photograph and standard sizes.
A follow-up question from the from Stark. Is wide-angle camera preferred?
Well, we prefer to incorporate as many cameras as possible. So wide-angle cameras will also be, well, part of our method. In terms of peripheral deformations, they are not really preferred. They will introduce more deformations. On the other hand, you eliminate the stitching process, so it could still, well, improve the accuracy of the overall method.
Another question in the chat. Registration with fundus photography is still based on macula and optic disc position. In other words, your method allows to adjust for scale, but not for rotation and translation.
Yes, for now that's the case. This is a very early proof of concept, only, well, intended to get a rough view of the performance of this method. And in a later stage, we indeed plan to also, well, improve the registration and not only use the macula and optic disc positions. But for now, well, we had to do it this way.
I want to thank the speaker. Thank you so much. Let's move on to the next talk of the session. The title of the talk is Considerations on Funduscopy Image Overlay for Target Delineation by Jörg Wulff from West German Photography Center in Essen. Dr. Wulff was responsible for the commissioning of the eye treatment option and starting the clinical program in 2021. Dr. Wulff, over to you.
Thank you. The stage was set by the previous speaker. We are still in the topic of funduscopy images for proton planning. I probably don't need to convince anybody that fundus images are of use for treatment planning, specifically for the delineation of the target. And this functionality is available in treatment planning systems. It was available for some time. We need two steps to use funduscopy images. First, we need to project the 3D eye model into a two-dimensional azimuthal pole-centric view, the fundus view, which then displays, as here shown in this image, the clip positions, the tumor base, the macula, the optic disc, and the great circles corresponding to the equator, ora serrata, and the limbus. And the distance from the pole along those spokes can then be given either in an arc length proportional way, equidistant, which is then the polar view in ray ocular, for instance, or one can try to model the properties of the camera. As we heard in the previous talk, there are some some degrees of freedom, and this is typically not well documented yet, how this works. And the second step is then a registration of the photo to that view. And we typically use two anatomical landmarks, the optic disc and the macula. And this has then, or this results then in basically 3 degrees of freedom. If we take this tumor base shown in this image here, then we have a possible translation, a scaling effect, and rotation. And we looked into the uncertainties and the corresponding margins for this registration process in 1 dimension. So basically along this red line here from the pole. For the translation, we may assume a standard uncertainty of 0.5 millimeter. So then as a function of the eye angle from the pole to the periphery, 90 degrees corresponds then to the equator. We have a constant contribution of 0.5 millimeter due to some uncertainties in localizing the model macula and optic disc and the corresponding points in the image. Then we may have some scaling effect. We may assume something like 5% due to the distance between macula and optic disc that has some uncertainties when measured in the OCT. And also, again, we need to find the model structures. And then this contribution is increasing towards the periphery. In that simple model, we have something between 0 and 1 millimeter. And then we may consider the patient head or eye rotation during image acquisition with 5 degrees. And then we also can calculate this 1-dimensional impact of changed chord length. And we can add up all in quadrature, and then following the concepts from Van Herk, derive a 2D margin, and that would be something in the order of 1 millimeter and 2.5 millimeter that are required just for that registration process if no other information was available. So what about the projection itself? I mentioned one can use this polar representation of the fundus, or of the retina, basically, displayed. So then this length A here is the arc length as a function of that eye angle. But the modern wide field cameras from Optos and Zeiss, they display the distance from the center in a so-called stereographic projection. And this is a tangents function, either as a function of this eye angle or this visual angle or camera angle defined at a certain point from the retina. So if this is overlaid, then we will have a discrepancy. We looked into this difference as a function of the eye angle, again, from the pole to the equator. And if we, for instance, take this tangents function of the eye angle, then if we compare the arc length, the polar view, and this display in the wide field camera, then we would have something like 5 millimeters discrepancy at the equator. So we cannot directly use the images. we looked a little bit closer into this effect with a defined retina. So we used a 3D printed retina cup for this eye model here, a very simple generic eye model. And this 3D printed retina has defined distances from the pole or angles from the pole for these little dots here. And here you see an example for an Optos Silverstone image. And these dots here on the outermost ring, they correspond to 90 degrees. So this would be the equator. And we know the distance from the first ring to the pole. And that, so we can scale these images as one would do with the information from OCT. And then we looked at the scaled distance as a function of the eye angle. Here shown is the arc length along one of the spokes. And here's the measured pixel distances scaled to that known distance to that first ring. And then we see here this difference between arc length proportional view and then this image as it occurs. And this is again the 5 millimeter roughly. And then we have the prediction following this stereographic projection, and that fits quite well. So if we know how this image is generated in the camera, then we can correct or deform it back to this polar view or arc length proportional view in ray ocular, and then manually register the images. And this is what is shown here. So the upper image shows the uncorrected Optos image registered to a corresponding eye model in the fundus view of ray ocular in this polar view. And as I mentioned, the outer ring here corresponds to 90 degrees. So it should coincide with this white line, which is the equator in the fundus view of ray ocular. And again, if you measure the distance here in the fundus view, it's again something like 5 millimeters as expected. If one then applies this first order correction, the points coincide with the equator. So it is possible to apply this correction from this wide field stereographic projection to the polar view in ray ocular. But there's much more, as we heard in the previous talk. There are certainly further aberrations in the real human eye, and we may have possible eyeball deformations. And also the camera software itself applies some automatic localization of that projection point, which is typically the macula. So in conclusion, it's tempting to use the funduscopy images. They have a certain role in target delineation, but they come with limitations and uncertainties. I think everybody is aware of it. Typically, the impact of these uncertainties is increasing towards the periphery. One can try to find an extra margin recipe for at least this registration. But it remains that there is, at least for the wide field, modern wide field cameras, this fundamental difference in the way they represent the retina, which could be corrected, but there is certainly more work needed. And until then, probably everybody agrees we need all the information available to have a proper target model. So, and with this, I'm finished, and thank for your attention.
Thank you, Dr. Wulff. Any questions from the audience? We don't have any questions in the chat window. Did you validate your methods for eyes with different eye length?
Sorry.
It's in the chat. Did you validate your method?
No, so basically we just used this one single eye model that was available for the experiments, and apart from that, no, we did not look into real variety as one could expect in the human eye.
Another question in chat from Martin. Have you considered to repeat the analysis with camera projection mode?
Yes, but I mean, as far as I can tell, the camera mode is still not a stereographic projection. So it is, as I see, nearly impossible to find any parameter set in the camera mode that represents this tangents function.
Well, thank you, Dr. Wulff. I believe this concludes the talks in the imaging section. And we have now open for general discussion and questions. I'm sure I missed some questions in the chat. So if the audience can maybe raise their hand or maybe retype their questions. And those questions can be for all the talks that we have seen so far, all the 6 talks. There's a question in the chat. What about 3D echo? And I'm not sure who is this, which talk is this addressed to? Alejandro, do you wanna? Oh, it's for Jan-Willem.
I know there have been some studies trying to do 3D echo for the eye, similar like when you have an ultrasound for a baby, but you see that in the 3rd dimension, the resolution of these echo ultrasound images is very low because the receiver has relatively thick elements. So there you generally see lots of interpolation. And when you take an ultrasound of a baby, you also see that they always take the measurements on the individual planes and not on the 3D images. They are nice for showing to family, but generally not so accurate for diagnosis. So there have been some studies, but I don't think they have come further than the proof of principle evaluations.
Thank you. There's another question in the chat for Alexei. What are the relative costs of tantalum clips against the ceramic barbell clips?
That I cannot tell you, unfortunately, because, you know, I got them for free. The company is more than willing to provide. I got 10 samples, which is kind of standard package. So the cost of them is probably, you know, probably going to vary between countries, even when you buy it from the same vendor. So I cannot answer that question, but it's, I do not expect it to be substantially different from what we already pay for tantalum rings. And I think, I don't know if Amanda Deischer is actually on the call. As physicists, we're fortunate not to deal with this, but maybe Amanda has any idea of how much this markers might cost at Mayo.
Also not something I have to deal with.
Yeah, we're just fortunate just to, you know, work with patients.
The first 10 are free, yeah. All right, Martin.
Yes, hello. So first, I just like to comment. I think it's great to see all these studies now on the accuracy and possible problems on this registration and how to interpret the data from them. I'm maybe a little bit surprised that this happens now and not maybe 10, 15 years ago, because I know the first couple of papers on this was really like 20 years ago. So I'm not sure why that is, but maybe now people found the time, and that is great. But I just want to get back to the very nice study that Jörg showed us, right? And the use of the camera projection. So in Ray Station, so I work at Ray, so I think I know most people here, right? And have been part of developing Ray Ocular and Ray Station. So we introduced these 2 camera projections, and we basically took what was ever in iPlan. So you guys would not have to take a huge leap, not even looking if they were good or bad. Say, okay, let's start here. What we did do was for the camera projection mode was to expose these these different optical parameters. They may be a little bit quirky, but they basically come exactly from what iPlan is used underneath the hood. We looked at the source code to do this because it was not documented anywhere. Jörg saying that they are difficult to understand, and they were, but actually in 2023B documentation we did put in the exact definition of that. So if you look in that manual, you can find it. But you know, I just like to cross correlate a little bit what the nice result from Leiden, what we showed earlier, where you could see this actually very good comparison with but that wasn't really clear. But they as far, so maybe Jan-Willem, you can comment on this, that you know there was, you know, you actually managed to find a set of parameters in Ray Ocular for these camera projections to get this almost one-to-one correlation in your study, right?
Yeah, so the idea is, and it's something which is a bit known in refractive surgery, that when you take the second nodal point, which is a very simple optical measure which you can easily obtain clinically, then for magic or nature or whatever reason, the angle at which the light ray enters the eye reflects the light ray, it exits this nodal point. And so this nodal point is basically a reference point from which the angles are the same. And I think the original camera projection, as it was in iPlan, takes also a reference point and then some fudge factor to calculate angles. But you can change in Ray Ocular this reference point. So when we said we want the reference point to be the second nodal point, and we change the scaling so that we can relate it to the angles on the fundus image, we basically use this linear relation, which is something specific to the eye. It probably has to do something with the shape of the cornea to link locations on your camera to locations on the retina. And so therefore it takes into account if a patient is very myopic, then the curvature and these angles change slightly. But these are things your ophthalmologist can easily measure for you.
So as far as to remember, Jan-Willem, when you showed me these results some 6 months ago or so, it was clear that the default parameters chosen that was used in iPlan and that we took as our defaults, right, were not very good. But they could be drastically improved by just changing a little bit. So the question, I mean, it would be very nice to see those great measurements of SN, you know, with the camera mode using those parameters that you came up with. And see, you know, who knows? I was so surprised to see actually the good results that you could show from. I didn't expect that. I always thought that we had to actually introduce a third. Maybe we do, but I mean some new projection method. But maybe actually that is at least going to improve a lot.
I think the mapping the SN people showed is very nice. I'm a bit worried if you have a longer eye, because then if you take a length measurement, the Optos also measures with angles, but then the thing you measure becomes further away. So with the same angle, you get a different distance. So I'm very curious to see how the polar projection method works if you have different eye lengths. And of course, with the more myopic people, we have a larger variation in eye lengths. And I think that's the elegant thing with the the camera mode, that you do in angles, and therefore you're invariant to eye length.
So that would be another reason to test the camera projection. And so yeah, please, it would be great to see that, Jörg.
Yeah, sure. I'm certainly interested. Just one comment. I mean, we had really problems to understand that the cameras, at least the two that we have available, the Optos and the Zeiss system, that they represent in this stereographic projection. And this is a fundamental difference to what either the camera mode or the polar view, this arc length proportional view is. And you can tune whatever you like. There remains this difference, this fundamental difference. So then if you want to have a camera model, then you would need to have a camera model that also considers this stereographic projection. And so you would need to extend this to that basic
Yeah,
problem.
and what I really like that you have a good model to test if it's correct, because some of the reports on the Optical show that after a software upgrade, suddenly the scaling is different. And then having a good eye model or on a different model to put in front of your camera to see that it's still accurate, I think is key if you want to start using this for treatment planning.
And then, of course, even if we have the most perfect projection model, we are still, you know, left with a macular problem. So
We have a few more questions in the chat window. The first one is for Jan-Willem. If one has a 3D MRI, is a CT really needed? Is geometrical distortion in MRI the reason for the need of a CT?
No, I think if you have a correct MR model, you can get a correct MR sequence. You can have differences or geometric distortions below 0.4 millimeters, so below all the other uncertainties in current ocular proton therapy planning. CT gives you bony structures, which is potentially nice if you want to map it to, I don't know, KV images. But for tumor modeling, the MR is sufficient.
Next question is for Riccardo. Did you compare your anterior model against the eye plane lid model rather than the skin plane?
So short answer is not yet, but in the presented case, actually the skin plane was upstream with respect to the eyelid. That's where we measured the 2 millimeter discrepancy. We observed more agreement where the eyelid was actually modeled in our, so where the eyelid was upstream with respect to the skin plane.
Next question from the chat. Are there substantial differences in optos projection depending on the lens thickness, also for pseudophakic patients with post-chamber artificial lenses? It's from Alexei Trofimov. Alex, you wanna maybe expand on the question?
I was just curious, you know, I don't know much about optics projection. There are always distortions. We're kind of used to it, right? So we may adjust our targets outline based on where the target is. Like we know there are more distortions for the peripheral tumors, right? So we all know that. I was just curious if anybody is aware of you know, the optics of you know, whether the patient is like with optics, you know, for those who had optics, they can push you close, you can be a little bit further out. There are many variations. Other variations, say, you know, we see some variations in the lens dimensions based on ultrasound. Many of our patients have intraocular lenses, artificial lenses. There are many different designs. Is that a factor in this, or is this just a distraction? Should we just kind of focus on kind of average model, not try to kind of overthink it and introduce too many parameters?
I don't know the optos that well, but if I look at refractive surgery, you see that there are basically two main elements in the optics of the eye. That's the cornea shape, because you have a very strong difference in the refractive index from lens or from air to cornea. So you want to measure your cornea correctly, and then the eye length, and all other parameters are relatively of less important. Of course, if you want to go subdiopter for your intraocular lens calculation, then you want to incorporate them as well. But getting a good cornea shape measurement and the eye length, which most biometers just give by default, I think then you're 90% or maybe even more accurate.
Jens?
Yeah, just maybe I can comment a little bit from my clinical experience, because you have, well, fundus composites and also we have some optos images, and we really didn't do any study to that, because we do multifunctional or multimodality cross checks using ultrasound and also OCT, and that, well, wishes all the uncertainties out, or in the end the tumor or the clinical target volume gets bigger. But what we observe is, which seems to coincidence what Jörg Wulff showed from Essen, when we model a tumor based on the fundus and it's going into the equatorial region, starting at the posterior pole, the and we just draw the contour on the fundus. In many cases, the tumor contour to the anterior part, to the equator, is a little bit overestimated. We can see this when we see measurements of the tumor or parts of the tumor in the CT, because we work also with CT and fundus. There we see an overestimation, but this is not a reason for us to, well, reduce this contour. Just to give one expression. And also, all our contours derived by fundus are cross-checked by ultrasound, length, width, height, and distance to posterior structures are cross-checked by measurements with OCT to be there on the safe side.
Any more questions, comments from the group? All right, should we basically end the first part of the session then and head over to the break? I guess. Well, on behalf of the organizers, I want to thank all these speakers from the first session, imaging, and we'll see you in, I believe, 40 minutes. Thank you, everyone.
So good afternoon, good evening, good morning, depending from where you're joining. It's reassuring to see some cameras on, so I know people are not sleeping or have not left the meeting. My name is Jan Hrbáček. I'm medical physicist at Paul Scherrer Institute, and it's my task to guide you through the next session. This session will focus on treatment planning for ocular proton therapy, and we have invited Dr. Linda Mortimer to give an overview for this session. Linda is a medical physicist working in Clatterbridge, and by now it's more than 10 years. She's in the field of the ocular proton therapy. So she has an outstanding experience with iPlan, and their clinic currently goes through the transition to Ray Ocular. So Linda, I hope you are with us. And the stage would be yours. Excellent, excellent.
So I'm just going to share my slides. Okay, you have that now?
Yes, everything seems to be fine.
Okay, fabulous. Thank you. Thank you, Jan, and for the invitation to give this introduction talk to the session. So as Jan says, this is very much an overview with content which I'm sure will be very familiar to most of you. So first of all, I'd just like to acknowledge some people for providing details and images for this talk. So I'll start by going over the fundamental elements of an ocular treatment plan and the main goals of the planning process. So then I'm going to present an overview and comparison of some of the features of dedicated ocular treatment planning systems. Then I thought it might be interesting to take a look at workflow, comparing the traditional type of workflow used, for example, with iPlan, with an example of the modified workflow that might be used when 3D image data is available in the treatment planning system. This is relevant as centres consider moving to a system which supports registration of 3D images. Although the focus here is on dedicated systems, we'll see later when I take a look at the choice of treatment planning systems based on survey data that actually some centres are using general purpose systems now for ocular planning. And finally, the final slide I'll present, based on survey results, a few points on what the future might hold for ocular treatment planning. So what are the fundamental elements? So first we have the eye model. A geometric model is used. In other words, an ellipse or spheroid is used to model the eye, which is scaled to patient-specific parameters. We have the tumour model delineated in the fundus view with images for guidance, with an apex and profile added to give a three-dimensional model of the tumour. So, as Jan-Willem discussed earlier on, multiple sources of data are used in the planning process. So multiple sources used to create these models. And this is important because many of the sources have uncertainties associated with them. The clips, of course, are currently a main important part of the process. They are key for both tumour delineation and precise treatment setup. And the eye model is fitted and reconciled with the clips, obviously before the tumour model is created. A mask is used for head immobilization and fixation light to provide a direction for the patient to gaze. In other words, to fix the eye in position. This requires active participation from the patient. So some centres use a wedge to reduce modulation or reduce entrance dose or optic nerve dose. Torsion or degree of twist of the eye at the treatment gaze angle is modelled with a neutral gaze or straight ahead gaze used as a reference. If lid tissue is in the proton field and affects the required range, then it should be accounted for. And this is done using a lid model or skin plane. Margins, both aperture and range of about 2.5 millimeters, have universally been adopted based on evidence and outcomes. Although there's some variation between 2 and 3 millimeters, and the images shows a reduced aperture or notch that we sometimes use at Classbridge for sparing of OARs. So the main goals of the treatment planning process: to select the best gaze angle, taking into account OARs and optimizing those, but also other patient factors, for example, gaze ability, eyelid position. In other words, what is achievable for an individual. And also to define the aperture shape in the beam's eye view, to determine the proton range or energy and range modulation, and to generate clip projections in orthogonal views relative to the aperture and crosswires. So here we have an overview of the dedicated ocular treatment planning systems currently in use. So iPlan was the first dedicated system, first developed at MGH in Boston, then by PSI and Clatterbridge. The first versions were quite primitive, but they've been updated over the years to allow fundus image registration, elliptical eye model and eyelid modelling function. So the first commercial system available was the Eclipse Ocular Proton Planning System. And then in around 2005, the Octopus system was developed and tested in parallel with iPlan. This was the first system that allowed 3D image registration, but its use was just restricted to Berlin. So Ray Ocular has been developed by Research in collaboration with the West German Proton Therapy Centre in Essen and Jens Heufelder. It's also based on the iPlan system. So with all 4 systems, planning is based on the geometric model concept. All of the systems support fundus registration, image registration, except for the Eclipse system. But having said this, at Krakow, they have developed a means of overlaying the fundus image for tumour-based delineation. So both the Octopus and Ray Ocular systems support 3D image registration, in addition to the fundus image registration. And this enables eye model refinement, definition of clip positions, and target definition. And with Ray Ocular, there is an improved dose calculation algorithm, which in the latest version models scatter from wedges. So here we have a comparison of the 4 systems. Fundus image and 3D image registration I've already discussed. All systems except Ocular use a simplistic method for determining dose distribution, and that is to use simple dose profiles with lateral and distal penumbra defined. Perhaps a key advantage of the iPlan system is its integrated image acquisition function, which enables online registration for clips for quick and easy setup at treatment. iPlan and Octopus both have eyelid modeling functionality, whereas the other two systems have a skin plane, which is used to represent tissue in front of the eyeball. And finally, something which is possibly a current issue for many centres is the fact that 3 of the systems are no longer supported. So now we're going to take a look at the traditional and modified workflows, highlighting some of the differences. So note that I've tried to keep the workflows presented here fairly general. I realise that workflows adopted by individual centres will very likely vary. So with iPlan and the Eclipse system, the workflow begins with the eye model, then patient simulation, at which 2D images are required for a range of gaze angles. The clips are located by digitisation, and eye model is fitted to the clips. This is done for each patient gaze angle, effectively producing a model for each one. One model is selected on which to create the tumour model and create the plan. The plan is optimized, and then 2D clip projections at the chosen gaze angle are generated. Then a final simulation session is held with the patient to check gaze accuracy, torsion, and lid position. In contrast, in the modified workflow, the planning can start as soon as the 3D image data is available. So image acquisition is the first step. The 3D image data can be used to refine the eye model, and it's used to identify clip positions, so not dependent on patient gaze ability, as can be the case in the previous workflow. The target's created in the fundus view, but it may also be edited slice by slice in 3D image views, as shown here. So the patient attends a simulation session later in this workflow to check patient gaze torsion, and the plan is modified accordingly. And then a final check may be made at a final simulation session before treatment. So now taking a look at choice of treatment planning systems. So in the Optic survey of 2015, 10 centres participated. Nearly all were using iPlan, and 1 centre in conjunction with the Eclipse system. In the latest survey, more centres took part, 19, because more are open now for ocular work. So the proportion of centres using iPlan is smaller, and there are almost as many centres using a general purpose planning system for ocular work. However, if we take a look at the number of patients planned using each system, you'll see that, most have been planned using iPlan. And even looking over the last year in 2023, this is the case. So it seems this is where most of the experience lies at the moment. So what about the future? So the obsolescence of iPlan and other systems may lead to a shift in Ocular for centres with dedicated eye lines. If more centres adapt general purpose proton systems and lines for ocular work, then we may see an increase in the use of general purpose planning systems. In the latest survey, a couple of centres indicated that they may consider using Ocular for certain functionality, so for example, anatomy and fundus registration, combined with a general purpose system for the dose calculation. So along with these changes, we'd expect to see an increase in experience of 3D image-based planning and the number of plans created with such systems. So perhaps there's an opportunity here as a community to produce recommendations and guidance for ocular proton planning as centres move away from iPlan where much of the experience lies, it may become more important to compile guidance on 3D image-based planning. But given the diversity of systems used, how feasible do we think this is? So I'd just like to thank you for your attention. Note these are suggestions based on survey results, so comments and other ideas are more than welcome. And I'll just end with a slide which shows the presentations and speakers to follow in this section. Thank you.
Thank you, Linda, for this very comprehensive overview. I'm checking in the chat if there are any questions, but that doesn't seem to be the case. So maybe on a little bit personal note, can you say how is the transition to ray ocular in Clatterbridge progressing?
Slowly. One of the things that is a bit of an obstacle for us is the fact that we don't have a solution for patient positioning. So currently we use iPlan for planning and positioning. And so we're looking into options for that. So with use with ray ocular. That's one of the obstacles at the moment. There are also many parts of the process and other systems, software related to iPlan that we need to sort of update and link so that they work with the ray ocular system. Yeah, there's a lot to do.
There's a questions from the audience. Chuck Bloch. I'm not sure about the accuracy of the survey results. Our center has treated over 50 patients a year with general purpose treatment planning system. Maybe can you comment on, there has been recently some updates of the survey, right? They are still not final.
There have been updates. I think it turns out that so many patients have been planned with iPlan. So the proportion of patients planned with iPlan does far exceed the other systems based on the numbers that we have accumulated.
Another question from Jay. Could you comment on the utility of having Monte Carlo dose calculation algorithms for ocular proton therapy? Are the current analytical algorithms sufficient for the required dose calculation accuracy?
Well, at our center, we don't use any algorithms for monitor unit calculation. We determine our monitor units by measurement with a calibrated ion chamber. So, yeah, I don't have the experience with algorithms for determining MU.
There has been a provocative question from Alejandro related to the roadmap for providing patient positioning for ray ocular. I take it, I suggest we keep this discussion for the general discussion at the end of the session. And on similar note, Andrzej Kacperek, how long will iPlan continue functioning with changing operating system? I suggest also this topic we leave for later on. And for the sake of time, we have to move to our next speaker, who is Martijn Hol, a medical physics engineer at Leiden, Netherlands. Martijn is now in the pursuit of a PhD at Holland PTC, focusing on the uncertainties in ocular proton therapy workflow. Martijn, stage is yours.
Good evening, everybody, and Jan, thank you for the introduction. And thank you for this opportunity to present this work on the uncertainties in the ocular proton therapy workflow. This research was funded by Varian. In the study, we looked at the uncertainties in the ocular proton therapy workflow to give an insight into the various errors and their magnitudes. A 2 to 3 millimeter margin is now often used, but in literature, an accurate margin calculation is lacking. The data presented in this study may be used for an margin calculation, but may also be used to see what the impact is for going to a clipless treatment. In this study, we looked to literature to find inter-observer errors and absolute errors for parameters within the category eye geometry, tumor definition, and clip distances. For the treatment positioning errors, we looked in the literature for systematic errors and for random errors. These are the results of the errors found in the literature. This data is based on 50 articles and our own experience. Because of time, I'm not able to go into every error, but I will show you in the next slides the references to these errors, and I will highlight some nice things. When looking at the actual length measurements done by biometry measurements, a lot of data is present in the current literature, because this data is also needed for treating cataract patients. Kruisberg and all showed that the inter-observer error was 0.01 millimeters. This data is good for healthy eyes, so eyes with cataract. But when an eye is infected with an UV melanoma, the measurement can be unreliable, as can be seen here in output of a Lancer measurement, which the left eye was the healthy eye and the right eye was the affected eye. Jasma and all make a comparison between measurements for the actual length between MRI measurements and measurements done by biometry. She saw that the absolute difference between those two was 0.3 millimeters if the measurements with biometry was reliable. We used these two references to get the inter-observer error for ultrasound and absolute error. When going to tumor definition, Jasma and all did a systematic review. In this review, 4 studies were included and 72 patients to get the absolute difference between ultrasound and MRI for the tumor prominence and for the basal diameters. The difference for the prominence was between 0.5 and 0.6 millimeters, and for the basal diameter was 1.4 millimeters. When going into inter-observer variation for the delineation of the tumor, Jasma and all showed that the difference was 0.4 millimeters. And these 2 studies are used to get the inter-observer variation for ultrasound. And the study by Pierre was used to get absolute error for funduscopy. When looking to the clip-to-clip distances, Jasma and all made a comparison between the clip-to-tumor distances retrieved during the surgery and with MRI. She saw that there was a deviation of 1.2 millimeters, a mean deviation of 1.2 millimeters between those two. But this was really subjective to the type to the shape of the tumor, as Jan-Willem already mentioned in his earlier talk. Going to clip distances, Lisa, in a study by Lisa, she compared the clip-to-clip distances between 3 modalities, MRI, CT, and KV images, and calculated the inter-observer variation. In the study done by myself, I looked to the patient positioning and also the clip-to-clip distance in a group of 60 patients treated at Holland PTC, where the absolute error was 0.1 millimeter. When looking for treatment and the patient positioning, Via et al. Evaluated the patient positioning, but I also did a study in a cohort of 60 patients treated at Holland PTC, and saw that the patient positioning error was there was a systematic error of 0.2 millimeters and a random error of 0.3 millimeters. For the proton KV coincidence and the beam range uncertainties, we turn to the International Optic Survey. Here, 10 centers participated, and the QA limits were asked. We took an average of these QA limits and saw that the systematic error was 0.3 millimeter for the KV coincidence, and for the beam range uncertainties was also 0.3 millimeters. When looking for the aperture manufacturer accuracy, there is not a lot of data present in today's literature. Looking at our own experience, we saw a systematic error of 0.3 millimeters. So in conclusion, we have an overview with the different errors. Looking at these errors, one can see that the largest errors can be found in the tumor definition. There are a lot of errors here presented, but this overview is still not complete. We are missing the inter-observer variation for the tumor delineation within iPlan and EOPP, but also the penumbra inaccuracy, the tumor interfraction eye movement, and TPS uncertainties for eye modeling, geometry, and density. In the data presented, we saw that a lot of times the errors were relative to one modality to another modality. But what is the current truth? In practice, most of the time, conservative approach is chosen, or the measurement which is the most reliable. And finally, how do we come to an accurate margin calculation? First, you have to think, how do we have to combine all these errors? And secondly, you also have to really take the European configuration into account. I would like to thank my colleagues for their participation in this study. Thank you for your attention.
Thank you very much, Martijn. I think this was a very useful overview and sort of a refreshing way of looking at the uncertainties and opening the discussion what kind of margins we actually need in ocular proton therapy. Based on, it might be a little bit hidden in the amount of numbers that you have provided. Would you be able that the problem is, our problem lies when it comes to the margins in systematic errors or the random?
Well, when looking to the formula of Van Herk, the systematic errors, is going to get the larger margin. But and also when you think about patient positioning, you only gave 4 fractions. So do you really have random errors in that?
There's a question in the audience, Alejandro again. So your conclusion related to basically asking what is your conclusion when it comes to a presented 2 to 3 millimeter margins that most of the centers are using? Are they adequate or not?
Well, when you look at the clinical outcome, they are adequate. But when you look at the outcome, for instance, for vision, you see that the most of the patients have vision loss. So I think there is an opportunity to gain some advantages. I think it's also really important to have this overview when looking, when going to, for instance, for clipless treatment. There probably on maybe the patient positioning, your error will be larger, but maybe you are going to use MRI, which is for delineation probably more accurate. So that may be balanced out.
And Jörg Wulff is asking whether the target delineation should be included in the famous 2.5 millimeter margin.
It's always that's a good question. I think if you take it into account that your margins will be even greater. So it's I think that's one that you really have to look into.
There are two more questions, but I also noticed that I'm starting to fail as the moderator of a session, and we are building up some delay. So I will take these two questions for the general discussion at the end, if you do not mind. We will be actually continuing on the same topic. Our next speaker is Daniel Björkman. Daniel is another PhD candidate in his final year at PSI. And within the scope of his PhD, he has developed a new treatment planning system prototype, and he's actually been utilizing this prototype to look into what margins we need in treatment planning. Daniel, the stage is yours.
So thank you for that introduction. Today I will be presenting to you my investigation into the suitability of lateral margins for ocular proton therapy. So what we want to do is we want to assess the suitability of lateral margins in Optis 2 at PSI and hopefully find something that can be used by other treatment facilities. So to do this, there are some challenges related to the limitations of conventional margin recipes. So most conventional margin recipes assume a generalization of motion with independent variables, a so-called random classification. But the complexity and variability of eye motion is difficult to generalize, and the random description of interfraction motion does not account for patient-specific drift. Additionally, the accuracy of describing daily setup uncertainties as random then decreases as the number of fractions decreases. So it's not suitable for hyperfractionated treatments. So instead of calling this random, we like to call it non-systematic. And how we investigate this is that we want to simulate dose accumulations of measured interfractional motion superimposed with probabilistic sampling of daily setup uncertainties. So in this study, we used the iPlan model exported from iPlan, and we consider its orientation described as a point where the model rotates and a gaze vector. The gaze vector then corresponds to the rotation of the model. So in this work, we use it's called Optis TPS. It's a TPS dedicated to ocular proton therapy, developed as part of my PhD project. So the interfractional motion is measured by Riccardo Via using infrared illumination required for 16 patients, and this motion is considered as accurate for this investigation. And on average for the cohort, we see that the gaze vector is about 4 degrees off from the intended clinical orientation, clinical fixation, and that on average the target center of mass is mean and max 0.5 millimeters and 1.8 millimeters off from the intended position. If you look down in bottom left here, we see that on this heat map that the eye is somehow deviating from the intended clinical fixation point. So here showing nearby the intended clinical fixation point by off. But looking at this alone, it's difficult to assess what is the eye actually doing during treatment. So we look here at this plot, checking one axis in isolation. We can see that we see a negative correlation with translation of the eye with rotation of the eye for that same axis. On a more core level, then for all 16 patients, we see this negative correlation in all 3 axes. And this means that the eye has a convergent motion. It's trying to look at the fixation point. So in order to combine intrafractional with interfractional motion, we consider the measured interfractional motion as a set of points and vectors, and the interfractional motion as a residual offset from the intended clinical rotation. We assess it analyzing the residual displacement with the clips, with the X-ray systems, and we superimpose the interfractional motion for each fraction with a sampled position of the interfractional motion, considering a probabilistic path through space of the patient anatomy. So like this, we can make a dose accumulation with the considered orientations. We can evaluate the suitability of a margin, considering the fraction of simulations where the target V90 approximate at 100%. We can simulate until convergence. So looking at the results, we see the clinical lateral margin of 2.5 millimeters. It has a very similar, suggesting very suitable, similar adequate target coverage as 2.4 millimeters. You also see up here. But if we reduce the lateral margin to 2.1 millimeter, then we can see already a drop of target cover, probability of target coverage for 2 patients. And this we want to compare to previous studies by Jörg Wulff. On the left here, we can see how we compare the methods that are used. So in this column here, we see that our simulations, considering interfractional motion by measurement, daily setup uncertainties by Monte Carlo sampling of distributions generated with our analysis of the clips. And we considered the systematic contribution as the remainder to the 2.5 clinical lateral margin. We compare this to Wulff's approach, where he considered the systematic contributions listed here. And he also makes a estimation of the non-systematic contributions with consider daily setup uncertainties as treated as systematic. And we also make our own estimation using Wulff's method, though with a re-estimation of the contributing factors to the non-systematic contribution. So if we look at the plot here to the right, we see that for looking at the lateral margin components for a penumbra 1.6 millimeters, the representative penumbra of PSI, we see that the complete margin suggested by Wulff's method approximately corresponds to where we see a drop of target coverage for not considering the systematic contributions. Moreover, using Wulff's method, but with our own estimation of the non-systematic contributions, we see an overestimation of the total lateral margin, giving indication of discouraging the methods suggested here. So In conclusion, we have a novel margin recipe suited for hyperfractionated treatments, and our simulations show a significant deviation from the lateral margins components when compared to wood. And so we observe a notable increased non-systematic contribution, while the systematic contribution is arguably overestimated in previous work. And here are my references, and my thanks to my colleagues at PSI and you for listening.
Thank you, Daniel. In the meantime, there's one question in chat from Jan-Willem. What is the accuracy of the dynamic gaze angle determination as that directly relates to the required lateral margin?
So the accuracy, I believe, has not been extensively validated, but we consider it as the best measurement probably in existence. So I cannot give you an exact a number, but we do see that it seems to make sense in the context.
Probably the ground truth here would be fluoroscopy of the clips during the treatment that you would compare with the eye tracking motion detection, but it hasn't been done. We don't have an ethical approval for it. What about treatment time necessarily linked to movement?
I'm not sure if I understand. So
well, probably the intrafractional motion is going to be proportional with the time required for the treatment, right? Or increase with the prolonged duration of a treatment.
Yeah.
Okay, again here I think we should be already one presentation farther. I will take the question from Jörg to the general discussion at the end. And thank you, Daniel. And I would like to introduce a next speaker, Ms. Juliette Kobus, who's a young fellow, and as she has written to me, she's currently awaiting the result on a selection exam to become a medical physicist. And the work she will be presenting here, she has done during her internship at the Centre Lacassagne in Nice.
Can you see well my presentation?
No, we see you. We don't see you. Are not sharing the screen yet.
And then?
Now it's perfect.
Okay. So hello everybody. I will present to you a study carried out at Lacassagne Center in order to evaluate Ocular and compare treatment plans computed with Ioplan and Ocular based on preclinical cases. So, currently we are working with Ioplan, but we wanted to study a new TPS Ocular from research. It offers new functionality for a more personalized treatment approach, and we ever use it for other treatment modality. It also takes clip density into account. It allows visualization of isodoses and dose volume histograms. It uses a Monte Carlo calculation algorithm, and it is a health organization certified software. So we realize that today there is no clinical cases study in comparison with other TPS. So the issue is what advantages does Ocular offers compared with Ioplan in terms of treatment plan for ocular tumor, and it is well adapted to Lacassagne clinical practices. Today we are treating some posterior tumors as uveal melanomas, but also anterior tumors as conjunctival tumors and iris melanomas. So to do this study, we create a 3D eye homemade phantom with radio-opaque tumor. We know well all density of the elements of our phantom and all dimensions. We also stick some tantalum clip in it. We also image our phantom with a CT scan with orthogonal X-ray in our treatment room, and we realize an optomap of it to see well the tumor. So to begin the study, we have to define an eye model and the clip position. So the reocular eye modeling mode creates well personalized model based on CT on MRIs. It is a really easy to use tool. All structures can be customized and adjust as artificial lens. It's also really easy to create and define a clip and their location. But the model definition is limited in the case of an atypical eye shape. There is no overall deformation of the eye structure set, and then there is also no connection between macula and optic disc. We also measure distance interclip on our frontal, and the distances displayed on ocular and eye plan were really similar with no difference superior to 0.4 millimeters. To continue, the first clinical case is a posterior tumor, the uveal melanomas. Concerning the tumor definition on reocular, we have a fundus view mode. The fundus view delineated tumors match well with its 3D location in the frontal, but in reality, we can't see the tumor well in CT. We have to work on optomap or funduscopy. And then we realize there is a huge mismatch. The solution will be that we have to consider the optimate image as a surface image of the tumor and not as a 3D prostate volume. Then we work on same planning parameters on ocular and eye plan to do a good comparison study. We can see that the BMI view and the treatment field projection are really similar on reocular and on eye plan. Only one element is different. It is the nerve you can see here. It's because the methods to find the optimal gaze angle are different in both TPS. In eye plan, we can find it easily with the mouse. In reocular, we have to find it a priori. So here, the CT was done when the patient is looking straight away, and that's why the nerve angulation is not linked to the eye fixation move. However, if we focus on the symmetric plan evaluation, we can see that there is no difference superior to 3% of eye doses. Only one data is missing. It is the Langus nerve, and this data will be wrong if we consider what I have just said before concerning the wrong position of the nerve. Moreover, if you want to have this data in millimeter, you have to add a script to your ocular workflow. Then if we focus on the isodoses form, we can see that there is no difference too. Here we can see that clip densities are well taken into account. The next case is with a wedge and bolus. It works well, and here again, there is no difference on dosimetric data superior to 3%. And the last case is about anterior tumors. For anterior tumors, contour tools on reocular are not provided, so we have to find an alternative delineation method, and that's why it's a bit difficult because we try first to work on the fundus view mode, and it was not right at all. So we work with a non-made method by printing a transparent hour grid and drawing corona slide by corona slide our tumor. it was quite long and complicated. That's why maybe a solution have to be proposed, and it would be nice to choose between an anterior polar view mode to draw conjunctival tumor, an iris plan view to draw iris tumors, and a fundus view to draw uveal melanomas. And it also will be really easy to work some photo and with our grids as in Ioplan. Even if our method was homemade, we can see that there is a lot of similarity between isodoses in Ocular and Ioplan and BMI-View too. It is the same in the case of the conjunctival tumor and on the iris tumor.
1 minute.
Yes. To do a quick review of all points to add up to Lacassagne Center, I first will talk about the eye modeling that have to be improved from the deformation eyeball, and it will be really important to link the macula and optic disc to keep the macula optic disc distance permanent. To define the tumor, it will be really easy to choose between a specific mode to define the tumor depending of its type. It is really important to consider the optomap image as a surface image of the tumor and not as a 3D prostate volume. Then, concerning the gaze angle search, it will be easier to work directly on the 3D model to find easily the optimal gaze angle as in Ioplan and to display the right nerve angulation related to the eye fixation angulation. One data is missing. This is the iridotic Langer's nerve, but it can be added thanks to a script. And note that we were not working with our mapping characteristics, so a fixed beam light instead of a frequency. Anyways, there is good functionalities that could increase planning treatment system in Ocular as its ergonomic interface, is DICOM compliance, its success use of MRIs and CT data. We also work with multi-beam management with success. We also like a lot those calculation algorithms and the way BMI-View and isodoses are displaying. Thank you for your attention.
Thank you very much, Juliette, for this nice overview. Questions from the audience. How did you manufacture the phantom?
It was a long work. We first buy some plastic elements and we fulfill it with ultrasound gel, and we put inside a nylon lens. It was difficult to build a lens, so we work with the disc and we say that it could be like an artificial lens, and that's all. It was really no-made things.
Looks nice. Okay, I suggest that we take the discussion on defining anterior tumors in ray ocular for the general discussion. Thanks again for your contribution.
Thank you.
And I would like to invite the next speaker, Dr. Heufelder, a medical physicist for many years associated with Ocular Proton therapy physics team, but currently a research associate professor and director of medical physics at the New York Proton Center. And he will talk to us about utilizing pencil beam scanning for treatment of uveal melanoma.
Thank you, Jan. Right now I cannot share
Juliette,
my screen.
Juliette, could I ask you to? Thank you.
Oh,
Hopefully you can do so now.
Thank you again.
Yeah. Can you see my screen?
Everything's perfect. Stage is yours. Thank you.
All right. Thank you very much. Yeah. Thank you, everyone. It's a great pleasure to be here today and share our ocular proton therapy experiences using modulated multi-beam in a regular gantry room. Let me start with disclosure. This work is supported by Varian Research Grant. And at the New York Proton Center, we are equipped with a ProBeam proton system. We have 4 treatment room, includes 3 gantry room and 1 fixed beam room, and also have a research room at the end of the beam line. We did reserve a space, if you can see that on the back of the fixed beam room, originally reserved for additional beam line for eye treatment. However, because the busy clinic, we never initiate this project. Meanwhile, we have very active plaque brachytherapy program at our partner hospital at MSKCC. And in later 2021, physician Dr. Bakker from MSK reached out to us, asked for the feasibility to apply the gantry-based ocular treatment because there's one patient not eligible for brachytherapy and looking for radiotherapy options. So that just triggered this project. And at the same time, we're looking, globally, there are more than 170 clinical PBS gantry rooms and more than 50 under construction by 2025. So if this solution works, even not like ideal perfect solution, but it opens another door to the ocular patient and provide the proton therapy solutions to them. So far, we already treated like 30 plus patients. For patient selection, here I show you the first 15 cases that we treated with their imaging and also their target contours. If we look closely, we will notice that there are some commonalities. Number one, some of the targets are most on the posterior side of the eyeball, close to the optic disc. And the other commonalities are a couple of cases has a very large target. Not all the diseases are UV melanoma, but they are all treated in the same approach. So stimulation, the purpose is to try to immobilize the patient and also keep the eyeball reproducible in their position. Before patient come for simulation, patient will get the titanium markers, typically 2 to 3. We will have discussion based on diagnostic imaging, determining the marker locations so surgeon can drop it in. And the patient come in with simulated with the bath frame and thermoplastic mask. We open the eye level so patient can see. We attach a gazing device to the mask and also attach a BB there. Ask patient to stare at the BB and so that the eyeball position can be more reproducible. And typically the gazing device is on the contralateral side, so we will try to turn the eyeball to the other side so the posterior target can be more close to the surface. Prescription 10 gray times 5. We use 1 millimeter dose calculation grade, 2 millimeter spot spacing. SFO or MFO, typically at least the 3 fields. Sometimes we also consider non-coplanar fields. Margin-wise, we use a GTV or CTV-based robust optimization, 3.5% range uncertainty, plus 3 millimeter setup uncertainty for optimization. Range uncertainty, often we just use a 2 cm range shifter. And if we use MFO, some like oblique beam may not need the range shifter. Just try to minimize the penumbra. Dose constraint, optimization-wise, dose constraint, we focus on cornea and hair. So later we have institutional dose constraint we'll show you. So markers location matters. If the surgeon drop the marker on the beam path, then it will limit the beam angle we can shoot to the target, and that will make planning really challenging. So we often have pre-surgery discussion on marker location. So this is one case for dosimetry, and the dose threshold is 2%. You can see because the cavity in the middle, it's hard to stop the beam. There are some low dose actually shooting into the cavity or even some small leakage to the contralateral side of eye, but dose level is low. This is 50%. Still, the dose cloud is pretty big, mainly because we don't have any apertures. Variant so far doesn't support the aperture. This is a 95%, so you can see it's quite conformal to the target for the high dose region. This is 3D-dimensional dose isodose curve to the target. Right side shows you the planning goals. Often the planning challenges are on the cavity, and also if we use a non-coplanar beam, sometimes the brain can be challenging to meet the maximum dose of 30 gray. IGRT, we start with KV alignment to the bony marker, bony alignment, and also the marker first. And then in the KV image, we'll also check the gauging device and also the BBs on the gauging device, make sure it matches to the contour from treatment planning. That means the simulation. Then we do con-beam CT, do three-dimensional match, and confirm the anatomy markers, and also sometimes look at the make sure the lens actually really turn towards the direction we try to gaze. And between beams, we do KV image confirm the alignment of markers and bone. And if we need more than one con-beam CT, we'll take image confirm the patient position. So the gauging device, reproducible gauging location, and patient follow instruction matters a lot. So during CT simulation, we do a couple of mini scans, make sure patient understand what they should do. So based on con-beam CT, we can reconstruct the treatment. Although this is not live, not imaging during beam on, but it's a pre-treatment image. You just try to confirm the margin-wise, set up everything. If patient, assuming if patient follow the instruction that how the dose looks like. So the target coverage wise, within 5%, and all for critical organs, the dose increase also within 5%. So as I mentioned, we don't have anything to track the patient eye location during beam on. So this is a project that we are working on. Hopefully that we can apply this into our clinic, and maybe it can helpful to even eliminate the use of markers if combined with con-beam CT and eye tracking. So in summary, based on ProBeam and Eclipse, we actually introduced ocular treatment based on regular gantry. And so far, we didn't have any toxicities or relapse reported. It's still like too short follow-up, maybe need a long-term data. We use the KV and con-beam CT for patient alignment with the markers. So future work will focusing on the implementation of eye tracking, and maybe if Varian can help us, and then we can work together, develop some aperture-based system, so can further improve the dosimetry. I want to acknowledge our team and also members from MSK, and especially Varian support. Thank you very much, and I can take any questions if you have.
Thank you very much. Also very interesting presentation. A question from Jens Heufelder. How would you compare your dose distribution to a stereotactic photon or CyberKnife plan?
We actually haven't do any comparison. So currently, we focus on the proton, and I think that's a good idea, and we can definitely do some dosimetry study. And currently, we are focusing on improve what we can do for our current clinic. Especially, we did some dosimetry study for aperture and looking to eye tracking. So those are something that can really benefit our patient.
How long does the treatment last with your solution?
Yeah, that's a good question. So because the target is so small, the beam on time is very, very short, typically like 30 seconds. Mainly it's the setup time. So if patient actually collaborate 25 minutes, I would say we can finish the treatment.
Alejandro's asking, how does your solution compare to the existing proton eye lines?
Yeah, good question. Actually, we talked about with Holland PTC, and they have the new variant eye line. So we will have some collaboration on that. We don't have results right now.
This 3mm setup uncertainty that you use in the robust optimization, do you think it's is that number justified? Do you think it's a good estimate?
Well, I would say so far we only have one patient that have challenge and really spend a lot of time during setup, but most time they can follow very well, and we can align very well. The good thing is we have volumetric image like con-beam. It can give us anatomy and also bony and markers. So those can help us to justify if the alignment is good enough.
Thank you very much. I'm getting notified that I'm running late. So if there will be any further questions, again, to the general discussion. I would like to invite next speaker, Mr. Zuoming Shen, an engineer from Department of Medical Physics at the Shanghai Proton and Heavy Ion Center. And he will talk about the multimodality image processing for eye treatments with light ion beams. Thank you for joining us at this probably very late hour for you.
Yeah. Thank you, James. Hello, everyone. Today my topic is multimodality image processing for treatment of eyes with light ion beams. Various imaging modalities with different sizes and resolutions are required for planning and treatment of ocular disease with light ion beams. These ocular diseases include subretinal neurovascular membranes, typically known as macular degeneration, ocular melanoma, and hemangiomas. Treatment information management and planning system teams was developed in-house that is capable of processing these different images. In teams, the MR images are used for delineating contours of targets and normal tissues. The MR images of a patient are scanned by Siemens magneton SCARA scanner at magnitude field strength of 3 Tesla using a 2-part flexible head core. This table shows the scanning parameters of the T1 weighted and T2 weighted MR images in scanned field of view, excision, spatial resolution, reconstruction, and sequence. While the XCT images in TIMS are used for portal design and radiation transport using a track repeating Monte Carlo algorithms. The XCT images of a patient are scanned by Philip Bradian's big bone CT using an orbital facial bone reconstruction protocols. This table lists the scanning parameters of the high resolution XCT for eye treatment. Compared that for typical large volume radiation treatments in spatial resolution, scanned field of view diameter, pixel spacing, and spacing between slices. The MR images are rigidly registered to the planning XCT images. While drawing, the contours may be simultaneously displayed on both image sets. The rigid registration in TIMS is a multi-resolution and multi-stage process that consider both the accuracy and the computation time. This figure shows the side-by-side XCT images and MR images with drawn eye contours. To design the portals, the XCT numbers are scaled, that is calibrated XCT number of L to 0 and water to 1000. And then the scaled XCT numbers are converted to relative stopping power for plan optimization and converted to material and density for Monte Carlo simulations. And the image artifacts can be overridden according to material or according to density. For Monte Carlo simulations, a lattice is formed with a material and density being assigned to each voxel. The lattice is automatically truncated to reduce the memory usage and increase the speed of simulations that use GPU accelerations. In detail, as shown in these figures, the truncation is based on the bounding box of the portal edge with additional lateral expansions. And the water equivalent values outside the external structures are set to zeros. And this figure shows the dose distribution and the dose volume histogram of a real patient case using carbon with 2 apertures. For patient alignment, high-resolution digitally reconstructed radiographics, DRs, are generated to match planar X-ray images acquired in the treatment room. The DR generations in TIMS also utilize the GPU accelerations and support image enhancement of different anatomies, such as bones, soft tissues, and the mental implant. These figures shows the DRs and the planar X-ray images of a chair case in anterior to posterior direction and left to right direction. In addition, a monitoring camera view image is syntheticized in TIMS to aid with patient setup. This image is compared with an image from an optical camera mounted on a beam applicator, while the patient is gazing at a blinking fixation light positioned at a given azimuthal and polar angle given by the plan. The synthetic images renders the surface of the drawn eye structures. In these images, the iris is represented by the black solid surface, while the scalar is represented by the white mesh. And the skin of the patient is also rendered using volume rendering with shading, while the optical camera images displayed in both the treatment room and the treatment control room to ensure the patient is gazing in the correct direction. Immediately after treatment, a patient is quickly taken to a nearby PET-CT scanner for imaging of induced radioactive isotopes. For verification of delivery, the scanned PET-CT images are compared with TIMS simulated PET images. This figure shows the comparison of the simulated PET images and the scanned PET-CT images. Details and of the simulation and the comparison have been reported by this paper. Now let's summarize today's topic. Various imaging modalities with different sizes and resolutions are required for planning and the treatment of ocular disease with light IO beams. A treatment planning system TIMS was developed in-house that is capable of processing these different images, encountering photo design and Monte Carlo simulations, patient alignment, and delivery verifications. In the future, we will develop contouring tools on fundus view to assist drawing tumors, especially for that flat tumors. That's all. Thank you for your attention.
Thank you very much for your contribution. Are there any questions? I wanted to ask about the PET verification. Is this something that you do routinely for every patient? And what would be the accuracy that one can achieve with verifying? But I assume you're using that to basically verify that you have delivered those to the correct location. Could you comment a little bit on the results that you see?
Can you see again?
Well, you showed at the end of your presentation about the PET verification. I was wondering whether this is something that you are using routinely for every patient, and what are the outcomes of such a verification?
Now, this is one step in the TIMS process. We are testing that, so we can't say that we have tested so many patients for that. We just tested for this under development software.
Okay, thank you very much.
Yeah, thank you.
There are no questions, so I suggest we move to the last speaker of this session. It will be another contribution from the Shanghai Proton and Heavy Ion Center, Dr. Rongcheng Han, a physicist at the Department of Medical Physics. And he will talk about using of Monte Carlo for those calculations for eye treatments with light ion beams.
Okay, thanks for the introduction. Can you see my presentation?
Yes, not yet in the presentation mode. Now it's perfect.
Okay, thank you. Hi everyone. My talk is the configuration and calibration of Monte Carlo-based dose calculation for eye treatment with light ion beam. In our center, nearly 40 ocular melanoma patients have been treated with intensity modulated carbon therapy in using single treatment plan system. While we are considering combine the beam applicator and the intensity modulate have the potential to reduce the dose to organs. And treatment plan system teams have been developed in-house that use a track repeating Monte Carlo algorithm to calculate the dose distribution. In order to apply this TPS for the ocular tumor treatment, we need to perform the configuration and calibration of the dose. Here is a figure shows our beam modulator and applicator. We have two kinds of ripple filter installed in the radiation head, and it is used to broad the bright peak width, and we have the range shift to shift the beam range. We use the patient-specific aperture to reduce the dose outside of the target. In our in-house TPS, we use a track repeating dose calculation algorithm. This was a Monte Carlo-based algorithm. We use a parameter. We use a phase-space file to store the simulated particle traversing a perpendicular to the beam and located in the radiation head. The range shift and the aperture have been modeled in the calculation, while the ripple filter affects the characteristic of the initial beam. So we need to generate a new set of phase space when the ripple filter is used. In this presentation, we only show the process of tuning the phase space for the proton beam with 3-meter ripple filter. The process of tuning the phase space we can divide into two steps. One step is tuning the depth dose. We use two parameters for each energy, mean energy and the standard deviation. We use these two parameters to tune the depth dose and compare with the measured dose. The measured depth dose will measure by PTW peak finder. During the tuning, we use two values to evaluate the difference between calculated and measured. One is the range of the bright peak, and the other one is the full width half maximum of the bright peak width. Here shows the result of the depth dose tuning. The difference between the calculated and measured FHWM and the position of the bright peak are all both within 0.2 millimeter. And the average difference between the calculated and measured depth dose was 0.098 millimeter for peak range and 0.046 for FHWM. After tuning the depth dose, the next step is to tune the lateral spot size. We use 4 parameters to tune the spot size. 2 are described the beam lateral standard deviation of Gaussian distribution in horizontal and vertical, and the other 2 for the angular distribution. We measure the lateral spot size at 5 positions in the air and using the MWPC. Since most of the patients were set up on the isocenter position, so the spot size at isocenter is more important. So here we show the deviation between the deviation of the spot size as isocenter. We can see that the deviation of the spore size are within -2% to 1% at iso-center. After that, we try to use different measures to do the dose calibration when the Ripple filter is used. The first one is we use Marcus chamber to measure the entrant dose. Then we use Faraday cap to calibrate the number of particle images from the radiation head. And we made a 30 by 30 by 30 cubic millimeter cube plan and to verify the dose calibration. Finally, we use this dose calibration curve to apply the dose calibration. Here shows 3 different depth dose profile. The blue dots was the measured dose measured by pinpoint chamber error. You can see it fits very well. And then we try to make 4 plans to do the dose verification. 2 are proton plan, which similar Ripple filter. One is with aperture, one without aperture. This is the aperture. And the other 2 is the carbon plan, which similar Ripple filter. One with aperture and one without aperture. Then we measure the dose at the iso-center using a Marcus chamber and the blue water phantom here, you can see. And we compare with the calculated dose. For these 4 cases, proton and carbon and without or with aperture, the dose deviation are both within 2%. After that, we try to use the clinical ocular patient CT to make plan. We make a proton plan with 3 millimeter Ripple filter with aperture on here left, and the one without aperture. We can see the penumbra is decreased when the aperture is used. And the organ, we also plot the DVH. The organ's dose is decreased by using aperture, while the dose of the target is not sacrificed very much. And we also we also make carbon plan, which is similar.
1 minute.
And compare with our clinical plan, which made by Siemens single plan. We also can see that the organ's dose is decreased. Here's the summary. Different measurement methods are used to perform configuration and calculation to make the dose calculation close to measurement. And by using the aperture and the inverse optimization for intensity modulation, that can improve the protection of organs in ocular tumor plan. But we still have much work to do. We need to verify the dose for inhomogeneous phantom and optimize the usage of double aperture and reshoot. And if we want to use carbon, we need to verify the carbon RD model. So that's all. Thanks for your attention.
Thank you very much for your contribution, Dr. Ronchen Hang. I don't see any questions in the chat. I was wondering for there's one from Martin Jansson. What dose grid resolution do you use for the Monte Carlo calculations? And what is the typical calculation time?
Okay, I need to say that in our in-house TPS, we are using it's not a real Monte Carlo simulation, it's a check repeating Monte Carlo based algorithm. And the calculation time depends on the target size and the CT resolution. For the clinical case, we use 512 by 512 CT. The calculation grade is 1 CT pixel is 0.94 millimeter, while we are trying to use 1024 by 1024 CT for planning, and the resolution will be 0.34 millimeter. Like for for the normal CT, for the bitrack CT, the calculation of one case, I think maybe cost 3 or 4 minutes. Yeah, for calculation, only for calculation, exclude optimization.
Thank you. If I could ask you, please stop sharing your screen. And I would like to ask my colleagues to highlight the speakers. And we're going to open the general discussion associated with this session. We are running roughly 10 minutes late, so we have decided that we will cut from the next break 10 minutes to anticipate for this. I have a few points that I was collecting as we went through the discussion. So there has been quite a few questions about margins. Alejandro Mazar was elaborating on whether we could comment on the PSI experience reducing from 2.5 millimeters to 2 millimeters. If I remember correctly, this was an anecdotal thing done sometimes in the years 2000, so long before I joined PSI. And basically, it has been demonstrated that by reducing margin by half a millimeter, there was a reduction or there was an increase of recurrences on some small patient group. And that basically led PSI to humbly return to 2.5 millimeters. And if I'm not mistaken, this would basically in line with the simulation that our student Daniel Björkman has done, because he has demonstrated that the 2.1 millimeter would be reducing or reducing the tumor control in some cases. Then Jörg Wulff was pointing to that 2.5 millimeter is a successful or proven margin by many centers, but commenting on that basically based on the simulation that was presented here, the systematic would not have as much room in the margin budget as needed. Jörg, Daniel, do you want to comment on this? Or whoever feels.
Yeah, I'm just asking, I mean, if, as was shown, there is less room for the systematic uncertainties, why is 2.5 millimeter then working? Are we too generous in defining the targets from the first place? Or is there more than just the physics involved in treating melanoma?
Someone was asking in the chat whether the target delineation should be actually included in the margin budget or not. And I have some sympathy for this comment because, for instance, what our ophthalmologists are doing, that whenever they are in doubt, we are always acting conservatively, meaning we are always increasing the volume. So I would say that the volumes that we are delineating are anyways already the upper estimate of what actually needs to be treated. And somehow it's probably not a correct procedure to do it like that, but basically I think that could be indicating that we don't have to take it into account as a systematic uncertainty because it's tackled elsewhere, not in the margin. There was another question related to introducing patient positioning for ray ocular. I'm not sure if it's a question more to our speakers or to Martin Jansson, but
I can pick that one up.
Good.
So ray ocular and ray station is a treatment planning system that is done in a treatment planning room. Setup is not part of treatment planning. Of course, I understand in iPlan you take all of these features and put them into one software, but ray station is a treatment planning system. So maybe the question should be, should you put that into ray ocular, right? Sorry, to ray care. It should not be in a treatment planning system. But there should be there could also be, you know, setup software used in the treatment room. And I know, you know, you Medphoton are working on this, I guess. So I think it's more a question to direct to them, or maybe to get RayCare and ask us to do your setup there. So it's not proper to have a setup in a treatment planning system. It's just wrong from but you know, I know that maybe you can comment on that they have sort of used our radiograph handling as in their setup, so it sort of can be used, but I don't think we will ever put efforts into making a streamlined setup functionality in the treatment planning system. So maybe you can comment on their use of the treatment planning system for a setup.
Yeah, I agree. I mean, I guess simply by intended use, it's not foreseen as a position verification system. But I mean, we use a workaround using the setup workspace of Ocular to load in every single image and then do a manual correction and basically recalculate this to a position offset. It's working, but it's not streamlined for that purpose.
Yeah, and the lack of streamline there, I mean, what takes time is not really related to the fact that it's not optimized for setup. It's just because it's sort of limited. The name is actually not really very good for that module. I mean, to set up, because it's not that it's but because you currently cannot. So we can import radiograph pairs, and we can overlay the model with the clips on that. But we don't have any, there is no way to digitize the positions of the clips that you see in the radiographs. And hopefully some days and then when you have done that, then you could automatically create this 6-dimensional offset between what you see in the graph and these apparent angles. So you can define the apparent angles and translations in this module, but you have to do it manually, which is obviously quite tricky. But this is also a tool you need, and the intent for this tool was to be able to use it to define the clip positions in your 3D model from radiographs, not for setup. But it appears to be basically the same functions, right? With the difference that, you know, also, like I know what you have in Clatterbridge and maybe also PSI, there's like a connection to iPlan and data flow between your setup system in the treatment room. That will not probably ever happen in Race Station.
Jens, you raised your hand.
Yes, thank you. I would give a comment or a question to the talk of Juliette Kobus. One thing regarding the optic nerve modeling, what we have seen in the following talk from Haibolin was nice to see the behavior of the optic nerve. Some part is rigid and the other part is moving. So it's principally a mixture between iPlan and Ray Ocular / Octopus, and it's difficult to say how to model this and how it behaves in each patient. Another thing is the iris modeling on the fundus. In principle, it should work. I guess he only modeled between the aura serrata and the limbus, and not between the limbus and the posterior pole. In Octopus, this does work, but I had no time to check it in Ray Ocular yet.
I can't see how that could work in Ray Ocular now, because the tumor is always created on the back of the eye, on the curved plane, right, on the retina plane. So, but it's on the list of things to do to basically use the current fundus view functionality and have a projection mode that is on the. So basically, that is the only thing we need to do. It's a lot of work, but still to be able to define that you want to do the projection on this iris plane instead of on the retina?
Well, in octopus, it still not lands directly on the retina. It lands on the well, extrapolation of the sclera in the iris area. But for iris tumors, as a sector, this is sufficient in our experience.
I think Juliette wanted to react. We don't hear you.
Can you hear me?
Yes, now yes.
Sorry, can you repeat again the question?
Sorry, we were discussing. You know, you raised 2 points. The fact how the optic nerve modeling is done in the system, and also the definition of the anterior tumors.
Yes, I think that if we want to define well the optic nerve, especially in ocular, I think that we have to know a priori the gaze angle. Because in this case, if we do the scanner with the right and the finished gaze angle, the nerve will well follow the orientation of the view, and it will be well undulated, related to the eyeball move. So I think it is the only way to define well the optic nerve on the CT. I don't know if you all agree, but it's the old solution that we have found.
Hans is nodding. Alejandro has the hand raised for a long time.
Yes, very fast one. I admire the work done by Martin and his team, but this time I want to argue with him. I think that the planning system is not limited to those calculations. And we also can admire the work done by Michael Goitin decades, 3-4 decades, and still it's very difficult to replace that system, as it was a full integrated system. So I think we can open our mind and think that the planning system can include something more than a dose calculation. And we need a tool to set up the patient based on what has been done in the planning. And it's a back and forward. So we are not going to conclude today, but just to argue that we can think about the planning system as much more than dose calculation.
There was a question also related to the presentation of Haibo Lin about what's the impact of the clips in regard to different beam angles on the beam, I guess then basically like radiation shade created by this.
Yeah, so if we did some Monte Carlo simulation, if the markers in the beam pass, and it will generate some shadow of around 11% of those drop behind the marker itself. So that's why we always have meeting before the markers drop, so that we can place it in the location more favorable to the planning.
Okay, so I'm getting notified that we are also running out of the extended slot for the discussion. So I would like to thank all the speakers. The coming break will be only 20 minutes, so we will reconvene at 8:10. And I would also like to thank to Andrea Denker for the fantastic job with the timekeeping and trying to keep me in lines.
So welcome back, everybody. So I think we'll make a prompt start. So welcome to the third and final session of this symposium on positioning and facility upgrade. So firstly, I'd like to introduce Petra Trinkova, who is going to give the introduction talk to this session. Petra is a member of the PTCOG Ocular Subcommittee. She's a medical physicist and currently works at the Medical University of Vienna. She has experience with ocular proton therapy from both PSI and Holland PTC. So I'm just going to hand over to you, Petra.
Thank you, Linda, for the introduction. Hello, everyone. It is my pleasure to give you like a brief refresher of the workflow on positioning in ocular proton therapy. So in my talk, I will be mainly talking about the dedicated ocular beamlines, and I will show you how the patient fixation, gaze angle fixation, and position verification and monitoring is performed. And then I will also show you two alternative workflows. One is a clipless based workflow still with dedicated eye line. And then I will talk also about a gantry based workflow with a gantry. What I would like to say at the beginning, so if it's not stated otherwise, the images are based on Holland PTC or New York Proton Therapy Center for the gantry workflow. Just to remind all of us, how does the dedicated ocular beamline look like? So what you could see here, there is a patient chair for positioning of the patient, which is just opposite of the ocular nozzle. At the end of the nozzle, there is a place for a patient-specific collimator together with a LED to indicate the gazing angle for the patient. There is some place always to insert the beam modifying devices to shape the beam in the depth inside the patient. And here you can see also the example of the imaging panel and X-ray tube mounted for the imaging and for the verification of the positioning. There is one more imaging panel inside the nozzle and one more X-ray tube behind the chair, but they are unfortunately not visible on this image, and they are both to get the perpendicular images of the eye. So how are we positioning the patient? The first thing we need is a dedicated rotating chair. And this chair has usually several degrees of freedom, and you can see it on this example. So for example, you can rotate the chair away from the gantry to enable the patient to enter the positioning chair. And then you can always adjust the head of the chair, the height of the chair, and also the position towards the nozzle to be able to fit to every patient that's coming for the treatment. Once the patient is sitting in the chair, we need to fixate the head. And for this, what we usually use is the head frame, what you can see here on this image. Behind, there is a head cushion to position the head in a vertical position and not moving it backwards. And then we have also a thermoplastic mask with a bite block, which you could see here. An example of the one shell thermoplastic mask with a bite block. And we will see in one of the talks of the Bas van der Burg that there are also the double shell immobilization devices, which will be the next talk after mine. So once the patient is fixated in the head frame, we make the holes for the eyes, and we can use the eye retractors to remove the lid to make the beam path clear. And this is the example from MGH, and you can clearly see here on this imaging how is the lid retracted, and it's not in the beam path for the treatment. And we can hear also the experience with the lid retraction from Jens Heufelder in the second talk in this section. Once we have the patient prepared for the positioning, the last thing that is missing on the dedicated eye line is the gaze fixation device. And you have a picture of the gaze fixation device on this slide. This is basically used to guide the patient to look in the direction that's defined from the treatment planning system. And with this slide, which is basically moving around, we are able to select any possible gazing angle, which is given in azimuthal and polar coordinates. And then once we know which angle the patient has to gaze, we switch on the light on this panel to guide the patient direction. And how does it work? So imagine you have a patient at the beam line. And once the patient is fixated, we just switch on the light. The patient looks the direction that it's supposed to look. And then we see that the beam path and the gazing angle was selected in a way to spare the organs at risk, which was in this case the lens. And we can apply the beam to spare the organs at risk. Here is the nice animation from the publication of Tariat, which is a Nice beamline. What is important for us, it's only this part when the patient is positioned in the in the beamline. We will hear something about the cyclotron, which is far away from this beamline in the last talk from Peter Corlett. And for this positioning, it's only this part which I'm going to talk about. So you can see the patient is right now sitting in the chair. The head is fixated. Eye is already gazing in the direction of the light. And so what we need to do is to perform the X-ray images to visualize the eye, which has the clips, what we have heard in the previous presentations, because with the X-rays imaging, we are not able to see the eye. So we are using the clips for verification and for the positioning. Here are the two X-rays tubes, which I was mentioning at the beginning. And there is also possibility to have a light field projection to project the light onto eye of the patient. So this is how most of the dedicated eye lines look like. Once the patient is sitting in the chair and we're getting the images, you can see here an example of two different anterior, posterior, and lateral images. On all images, we can see the position of the clips. These are actually the images used for the treatment planning. So for the treatment planning, you get several orientations with different positions of the clips, where it's also important to know the numbering of the clips to be able to relate correctly the position of the eye. This is inserted into the treatment planning. From the treatment planning, you will get the position of the treatment of the clips for the gazing angle that you would like to treat, and you just check during the verification if the clips are in the planned position. The imaging, especially from the beam side, is performed at the beginning without the aperture to be able to see all the clips on your image, because once you place the aperture of what you could see here on this example, it can happen that some of the clips are hidden by the aperture, and therefore you are not able to see all the clips for your position verification. Once you have the images, they are usually inserted in the positioning verification system. Here I have two examples, one of the commercial system used at Holland PTC, and also one of the in-house development system also used at Holland PTC. And basically from this clips position, you are able to see first if you need to adjust the chair, and you are able to coordinate the chair position in all three directions to match the clips. And then you are also able to identify if the gaze angle is not matching, and you have to acquire different images at different gazing angles, which depending on the difference in gaze angle can mean sometimes even replanning. But this is basically how the system looks like and the clips that you're trying to match in the positioning. Once you have the eye in the correct position, and you are ready for the treatment, it's always necessary to monitor the position of the eye. And for this, we can use a small camera mounted on the nozzle. This is example from our Paul Scherrer Institute. And this camera is monitoring the position of the eye during the treatment. And you do it with the manual monitoring, when you basically draw the iris and the contours of the eye on the camera, and then you just observe if the eye is moving or not moving during the treatment. If the operator notices that the patient is moving the eye, then usually the beam is paused and patient is guided back to the treatment position. And afterwards, once the patient is in the correct position, the treatment is resumed. So this was the example from the dedicated ocular proton therapy with clips, but there is already some clipless based positioning, which is mainly used for anterior tumors like iris melanoma. This positioning is based on the light field, and I'm not going to tell any details about it because we will hear about clipless positioning in the presentation of Catherine Nourayen. But this is one of the alternative workflows that I wanted to briefly mention today. Second alternative workflow will be also very quick, because you have seen the slides already in the presentation of Haibo Lin today. So just to remind you of what you have heard in his presentation, that in case you are going to treat the patients on the gantry system, the patients are lying on the couch, so it's not anymore upright position, it's lying position. The patients receive the BOSS frame and thermoplastic mask. In this mask, you have a hose again for eyes positioning. And then there is a gaze fixation device with a marker, and the patient is gazing straight. So compared to the dedicated eye lines, we are not changing the gaze direction of the patient, the patient has just one gazing angle. And for the positioning, we can use the opportunities that gantry offers. So there is possibility to use KV alignment for the bony anatomy and the markers at the beginning. And afterwards, it's also possible to use cone beam CT to perform the matching on the 3D anatomy and define the final pitch, roll, and yaw, and also check the marker alignments. As on the gantry treatments, the treatment is performed from several beam directions. It is usually KV imaging performed before each treatment field to check that the position of the eye is still matching. So with this brief overview, I'm already coming to the summary. So what you could see that current status in dedicated beamlines is to treat patient in the upright positioning, use rigid head fixation, and use variable gaze angle for the treatment. In comparison to gantry treatments, we treat patients in supine positioning with rigid fixation and with straight gazing angle. Most of the tumors are currently treated with a clip-based positioning, but there is clip-less positioning for anterior tumors already clinically implemented. And in the future, there is a lot of research ongoing for clipless positioning treatment for all tumors, but I'm not going to talk about this as I wanted to focus only on the clinical facilities. And with this, I would like to thank all the people that have provided the images for this presentation, and also PTCOG Ocular Subcommittee for giving me the opportunity to present the positioning here. And thank you for your attention.
Thank you, Petra, for that very excellent and comprehensive overview and introduction to the session. I don't think there are any questions in the chat. Does anyone want to ask anything verbally? I think we've got a couple of minutes before the next presentation is due. I wondered if you had maybe something to comment on correction methods that might be available for gantry and dedicated beamlines.
Mm-hmm. I don't have personal experience with the gantry treatment of ocular tumors, but I guess then you have all the functions that the gantry offers you. So you have the pitch, roll, and yaw of the table, and you're adjusting the patient by the positioning. And if you don't match the markers, you have to then reposition the patient. For the correction on the dedicated beamlines, usually from the clips, you are first trying to check if you can adjust the positioning based on the chair position. So you try to match the clips with shifting the chair of the patient. And if you still see that the clips are not overlaying, you're trying to identify if there is can be done improvement by changing of the gaze angle of the patient, or if there is a torsion in the eye which you need to correct, but not all the systems allows to correct for the torsion in the eye.
Thank you very much. Any other questions? Some chairs have a head tilt axis. How often is this used?
Yes, I don't know how often is this used, but you're right. There is also head tilt, and I don't know how often is this used.
And there's a response from Alexei, who says they use it 10 to 20% of the time.
Thank you, Alexei.
Thank you very much. So we'll move on to the next presentation. So our next speaker is Bas van der Burg. He's a researcher from Delft University of Technology at the Department of Precision and Microengineering. So he's going to tell you more on his work on double shell immobilization for ocular proton therapy. So I'll hand over to you.
Thank you for the introduction, Lina. So let me share my screen. Yes. So first of all, I would like to start with a disclosure, as my project is funded by Varian. So currently clips are sutured to the patient's eye for position verification, but ideally these clips are not used as they put a considerable burden onto the patient. Therefore, a different method for defining the tumor position is needed. As my colleagues from Leiden already mentioned,
MRI can be used to accurately determine the tumor position. However, MRI scans are performed in a supine position, whereas the treatment is done seated. Therefore, to enable clipless treatment, an accurate mapping from the planning scans to the treatment chair is required. To enable this, we want to make use of a single immobilization device for both the scans and treatment. However, there are no immobilization devices currently available which are used in both positions. Nonetheless, there is ample experience in these positions separately. Therefore, we investigated if an immobilization device commonly used in radiotherapy can also be used seated. For this, we tested 3 types of masks with integrated bite block for macromatics in a group of healthy volunteers, a single shell positioning system consisting of a front shell and a strap pressing the head into the shell, as shown on the bottom right, which is somewhat similar to what is currently used in the ETR. Second, single shell positioning making use of a common headrest, as shown on the top right. And lastly, a double shell positioning system consisting of a front and back shell. So to assess if these masks can actually be used in a seated position, we made a setup which allows to immobilize the participants in both the seated and supine position. Displacement of the mask and skin around the eyes and nose were measured through an optical measurement technique. And based for this, we attached 2 sets of cameras rigidly to the setup. Experiments were conducted in a group of 15 healthy volunteers, with each mask being evaluated in each participant with 3 repetitions per mask per orientation, where it must be noted that the participants are released from the setup when the orientation is changed. Additionally, during each measurement, 10 separate pictures were made for verification of the results. These pictures were part of the optical measurement technique called digital image correlation. By comparing the shift of a speckle pattern applied to the object of interest on consecutive images, you can determine the displacement and deformation of this object. To assess the accuracy of this method, we performed some additional experiments showing that accuracies can be achieved in the order of 1/100th of a millimeter. We applied the speckle pattern to different places on the mask, resulting in around 16 different measurement patches. So now I would like to tell you something more about the results. During the experiment, we also conducted a survey to assess participant experience with these masks, showing in general that the participants favored the double shell over the other masks. Now going to the more technical data. So we collected a vast amount of data, which I will be indicating here. So here you can see the displacement of the different measurement patches we used, indicated by the arrows on the left and the different colors on the right. However, for the remainder of this presentation, I will be focusing on the measurement patch on the forehead. But before zooming in, I would like to briefly show you the results of all participants for the double shell, showing the amount of data we collected for each participant. Zooming in on the results, we had to verify the accuracy of our measurements, which I will be now showing for the double shell, but is equally valid for the other mask. So as you can see here, the deviation between the measurements is relatively small between the images, showing a spread of around 0.05 millimeters. The deviation between the measurements, which can be considered as a measure of the repeatability of the measurement and positioning, is shown over here, showing a spread in the position of the mask of around 0.45 millimeters. When we now look at the displacement of the mask from supine to seated, it can be observed that for the mask, the majority of the measurements in the different directions is below 0.25 millimeters, and the mean 3D displacement varies from 0.42 millimeter for the double shell to 0.63 millimeter for the single shell. Here it must be noticed that the measured displacement are in the same order of magnitude as the deviation between the measurements. When we now look at the displacement of the skin around the eye, which we considered as an estimate of the positional shift of the eye itself, it can be observed that the displacement, but also the spread, is considerably larger. This can be attributed to the flexibility of the skin, which we also observed visually, whereas the position of the eye itself remained fairly constant during the experiments. This can also be seen over here, where the eye remains quite stationary, whereas the skin moves quite a lot. Therefore, these measurements can only be considered as a rough estimate of the positional shift of the eye itself.
1 minute.
Which brings me to the conclusion of this presentation. So from the experiment, we have shown the use of a double shell immobilization is feasible in a seated position. However, still some open questions remain. Therefore, the next step will be to assess the mask in a clinical study where the clips can be used to accurately measure the position of the tumor and eye, further validating the mask. And with that being said, I would like to acknowledge all people assisting in this research and would like to thank you for your attention.
Yes, thank you. That was really interesting. Excellent. Just looking at the chat. I think that is a question for the previous speaker. Does anyone have any questions for this presentation? I'll come back to that one in a minute. I was just wondering, why do you think the participants, what was it that they liked about the double shell? What do you think was favorable about it?
So first of all, it were healthy participants, but in general, they favored the fact that they were more, they felt more secure in that sense. So they were more, that they couldn't move less. And also, which was a bit counterintuitive, but most participants felt that the double shell showed less pressure points compared to the single shell we were testing. So yeah, that's why that were the remarks the participants gave, why they favored the double shell over the other two masks.
Yes, thank you. Any other questions for Bas? And there was a question referring back to Alexei's point, I think. In which situations, indications do you use the tilt, was the question.
Yeah, thank you. I thought this was a direct message, but I will respond for the benefit of everybody.
Okay.
So we do not have tilt on the chair. We do have a tilt on the head frame. That's not attached to the chair. It moves separately. So we have 3 degrees of freedom on that chair. So most often we'll make a correction, like pitching chin up like this when we retract the upper eyelid. So that also helps to move the periorbital ridge out of the field. Occasionally we'll do the same, like pitching down when we try to retract the eyelids. Sometimes we would rotate the head like away. So that would be done to kind of to rotate the canthus and punctum out of the field if possible, because ophthalmologists notice some toxicity in those organs. So we do use it fairly frequently. I would say definitely more than 10%. I cannot say for sure, we never took statistics, but it's between 10 and 20%. We do not tilt. We do not tilt head like this. This is, you know, there's actually no possibility for that. So it's like 2 degrees of freedom. Thank you.
Thank you, Alexei, and thank you, Bas, for your presentation. So moving on to the next speaker, Jens Heufelder. So Jens has worked for over 20 years as a medical physicist in the field of ocular proton therapy, mostly in Berlin. From the end of 2006 to 2008, he spent some time at PSI to set up and modernize their eye line, the Optis 2. From 2009, he has led the medical physics group at Charity's ophthalmology department, working with also ruthenium eye plaques from 2011. So in 2022, Jens became the co-chair of the PTCOG subocular subcommittee. So his presentation is lid retraction in ocular proton therapy, 25 years of experience.
Thank you, Linda, for the very nice introduction. Just starting, and I will also come back to the head tilt theme. Motivation. Well, why do you want to use lid retractors? Because for the reduction of the radiation-induced side complications of the eyelid, like dry eye syndrome, loss of eyelashes, as seen here, logophthalmos, and also seen here scarring of the eyelid. And these last two parts maybe can lead to an enucleation of the patient, even if the patient has good sight and even if the tumor is controlled. So how do we do this? Well, also here, see here, patient immobilized by combination of bite block, head mask. Also here we applied a light head tilt, especially to make room between here the upper part of the eye and the bone. And we apply specific lid retractors, which were made of spring steel wire for the upper eyelids and for the lower eyelids. Then we had designed some small universal, and in rare cases, in the earlier times more often, we use a modified eyelid spreader, where we just drilled in here some holes to also better secure the retractor. So in which case do we use which retractor? If we start with the central field, here you see the light field of this patient positioned. It's a full iris irradiation. Then you can, for instance, use this normal lid spreader, and here you see it on the X-ray. It works quite nicely. If you go to a large temporal field, then we use this one with 2 supports, or at least 4 supports for the upper eyelid, and also 4 supports for the lower eyelid to get it up and down, and also the small one to get the temporal part of the eyelid out of the beam. I have to say our light field is about 1 millimeter larger than the proton field at this point. If you have a nasal field, you can also use the spreader and also add an additional retractor. And also for the nasal fields, we often use the rotation of the treatment chair to get more room between the nasal part of the eye and the nose. And these rotations can go for the chair rotation about to 20 degrees, and for the head tilt 20 degrees back and maybe 5 to 10 degrees to the front, depending on the tumor site. Head tilt used, for instance, for superior field. When I used it, here you can see it also. And also we have one retractor, a wide one, to retract the upper lid and the lower lid with this one. If it's a wide inferior field, then, well, same. Maybe head tilt to the front, and also these 2 retractors. And here also you see it on the X-rays, where the field is clearly outside, or the retractors are clearly outside of the treatment field, which is indicated red. So if you have a very large field, then you can use several of these small lid retractors and do some kind of contour modeling. One of our radiotherapists is a fanfon, and it looks like a sun, so we call it laser sun. And here you see also in the treatment planning, the position of the clips, the contour, and also here you see the modeling of all these small retractors. Also, the advantage is you can really go slowly through it and induce slowly force to the eyelid. Of course, some treatment fields are too large. Then we do some alternating between upper and lower eyelid. The idea is only to apply 30 gray in total to the lid and not the 60 gray. So in this example, we got the upper eyelid free and we are in the lower eyelid regime. But here we have also to take into account that this part of the retraction will not interfere with the proton beam or the range. And on the next day, we will get the lower eyelid free and put some more dose on the upper eyelid. Third day, again, will be upper eyelid and then lower eyelid, so that the eyelid has some time to heal and cope with the situation. This was a quite large field from last week. When this is not possible, in rare cases, also we use the lid down approach. Here, it is very important that you bring the lower eyelid out of the treatment field and then use some tape. It's also done at Clatterbridge, and pull down the lid by the tape. This can work nicely for fields at the upper part of the eye. Here you see it from the frontal and the X-ray images to it. You only see one retractor, the other not. Of course, the patient has then to fixate with the healthy eye. And after some time, you will observe some burning, but this kind of burning heals quite good. So results. We need strong threads for pulling the eyelids and strong tapes for fixation, because if you do not use strong tape, the patient may have the force to bring or move the retractors back in. Superficial anesthesia is necessary. Sometimes patients faint during plant simulation. It's about 2% because of pain or stress. For that, good empathic handling of the patient is very important. Some patients like it to have a stress ball in their hand to squeeze it, to write about it. In some cases, we have to add additional painkillers and add metamimosol. In few cases, we need additional laproserpan to reduce anxiety and stress. And a head tilt or share rotation can help to get the eyelid out of the radiation field. Head tilt and share rotation, on the other hand, and lid retractors can influence the gazing ability. So sometimes an adaptation of the treatment plan is necessary, which leads to a reduction of the polar angle by up to 10 degrees. And larger irradiated volume of the cerebral body is the price we have to pay. But in most cases, this is still tolerable. So results, we have no eyelid involvement in most of our patients, over 97%. Minimal eyelid involvement, less than 1 millimeter, larger than 1 millimeter, alternating between both eyelids in 26 patients of these over 4,000, and lid down only in 6 patients. In 2 patients, the lid was part of the CTV because it were conjunctival melanoma. So in conclusion, lid retraction is a good method to minimize radiation-induced side effects. Sometimes additional medication is necessary if the eyelids or lid retractors are in the treatment field. Their influence on the dose distribution has to be checked. Treatment to the upper lid might be an option, but then you have to model the eyelid as shown before, and alternating irradiation of upper and lower lid may be an option for a large field. So very important, good empathic handling of the patient is very, very important. So, and thank you for your attention, and we all have to remember ocular proton therapy is teamwork.
Thank you, Jens. That was very, very interesting. I think maybe just time for 1 or 2 questions. So from Jan, for alternating eyelid approach, do you have 1 or 2 plans?
It depends on the patient. Sometimes we can do it with 1 plan. Sometimes, if it's very complicated, we have 2 plans, and we have to handle these 2 plans.
Thank you. From your Wulff, are the lid retractors homemade, or where do you purchase them?
Yes, they are homemade, and we have a good mechanic who can build it. It's very teeny neat. Maybe the kids retractors from Ultimate might be an option for the modeling these very small ones.
And I think we're getting more questions through. Maybe just quickly before we move on, have you considered other materials instead of steel?
We tried this with plastic years ago to do not see any radiation, but then you have the disadvantage you do not see the lid retractors on the X-rays, which also is a good point for confirmation of their position.
And how do you sum up the dosimetry when combining two plans?
Usually the gazing angle stays the same and the two plans might be only a little bit rotation, so we think that's not so much influence on the dosimetry. And in critical cases, well, we just have two plans and say tumor is identical and the rest is about identical. So because we cannot sum up an octopus, unfortunately.
Okay, thank you. And thank you for the excellent talk. So moving on, our next speaker is Catherine Naray. Catherine has worked as a medical physicist at CPO, Centre de Proton Therapy at ORSA, ever since it was founded. So her career started with protons and continues with protons. Her presentation is on clipless positioning. So thank you, Catherine. I'll hand over to you.
Thank you, Linda, for your presentation.
Okay, so I will try to go fast. Do not hesitate if you have any question at the end, and I will come back on the slides. So we have been treated almost 8,600 ocular treatments since 1991. And for the last 2 years, it was a little bit more than 400 patients a year, which corresponds to 8 to 12 treatments per day. Most of them have clips, so it's almost 85%. But we will now consider not clipless positioning as the talk, not just before, but not clipless positioning for uveal choroidal melanoma, but more for iris melanoma and conjunctival melanoma. So regarding the tools we have a PPS chair. As most of you will use thermoplastic mask with a bite block with 2 eyelid retractors, which are not homemade, unfortunately. We have 2 infrared camera. One is on the beam using a mirror of 45 degrees, and another one is on the snout mounted. And we have the diode for the gazing angle. So the patient is seated face of the proton beam. We have laser to check the distance to the aperture, and well, I think same methodology as most of you. Regarding the modelization, we draw the tumor base on I-plan front an I-plan polar view, and we use a margin of 2.5 millimeter. We deliver 7.5 gray cobalt equivalent and 8 fraction on 2 weeks, so 2 times 4 days. For the iris melanoma, we draw the tumor base on the polar view, but on the front eye surface. Same margin, 4 fraction of 15 gray. And we use the beam side view to position the patient. We define the gazing angle to minimize the eyelids on the radiation field and to get the tumor almost perpendicular to the beam axis. So for the conjunctival melanoma, usually we have a gazing angle different from 0. And for the iris melanoma, we can treat patient looking straight ahead. So historically, we were positioning the patient using only the light field. So we use some paper with millimeter graduation. We measure the light field regarding to the limbus, and we compare to the beam eye view get from eye plan. So we measure the horizontal and vertical distance. And there was a double check with the physicist and the radiation oncologist. During the treatment, we used the infrared camera, which was mounted on the snout, to check that the patient was in position. So the treatment time was almost 1 minute. And the gating was manual, which means that if the patient moves, the therapist has to stop the treatment, and it's not automatically. The accuracy of this positioning depends on the way to measure, so there is some user variability. Depends on the side of the camera, because on this image you see correctly the limbus and the lids, but sometimes it's a little bit more difficult. And the therapist had some lack of self-confidence to make the measurements, so they usually need the physicist and the radiation oncologist to come and to confirm that the position is okay. And for some patients, not all of them, maybe 5 or to 10% of the patient, maybe less even, the gazing angle may change when we just switch on the light field, because then they do not look at the LED, but they look at the light field so straight ahead. So it can have some influence. So now we are using a beam eye view camera, and the positioning is maybe a little bit longer, but we are more confident in this one. We use it since 2014. So the first step is the patient looks straight ahead, and we have some papers which are on the aperture. And so we see the limbus just here in the middle. Once the patient is aligned in this way, we ask the patient to look at the gazing angle we chose during the planification. We check that the limbus projected correctly, and then we just switch the chair as planned on the TPS and check that everything is correct. Sometimes we have to move a little bit, but usually it's less than 0.5 millimeter. And using that, then we double check using the light field. I will come back to it. When we do not have limbus in the field, we add a third step position. So we have the straight ahead position, then we check the gazing angle, then we move.
One minute.
Yeah, okay. Then we move the chair with a large aperture, and then we use the treatment aperture. Between step 3 and step 4, we use the lateral camera to check that patient didn't move and that we can treat. Then we double check with the light field. The beam eye view camera help us to record the images, and so to have some medical legal trace of the treatment. We are asking now if the red light field we are using at the end is really an essential step, or if we can just remove it, because we never moved the patient once the camera was okay. We evaluated, but not really. It's more the feeling that the accuracy is within 0.5 millimeter and 0.1 with the side camera. Thank you for your attention and sorry for the mic trouble.
Well, thank you, Catherine, and thank you for your colleague as well for stepping in. Thank you very much.
Linda, for this.
I think in the interest of time, we will move on to the next speaker. So I am now going to introduce Peter Corlett from Clatterbridge. So Peter is an electronics engineer who graduated in 2003. He spent the majority of his career so far working in research and development for new particle accelerators within national laboratories in the UK and Australia. He joined Clatterbridge in 2021 specifically to lead the efforts in modernising the cyclotron. So his presentation is on extending the working life of a low energy isochronous cyclotron for ocular proton therapy. Thank you, Peter. I will
Thanks for
hand over.
that. Can you hear me?
Yes, we can hear you.
Yeah, so thanks for the introduction. And after so many scientific talks, I'm going to seem like a caveman hitting rocks together as an engineer. Sorry, my dog's barking as well. But my main job is to look after the cyclotron engineering and at the moment leading the upgrade program. So by way of background, our machine was built in the early 80s, originally for a clinical trial of neutron therapy, and started treating eyes in 1989. So it's old. We don't have any support from Scanditronics, who built it, and haven't had for a few decades now. So in about 2019, there was a general expectation amongst the staff who worked at Clatterbridge and the management that the service was going to close down quite imminently. There were key staff retiring and not being replaced, so there was a gradual decline in everything. The NHS really had no plan for replacement of the service, and the doctors who refer their patients to us were very worried. And because of that, an alternative plan to terminating or building a new machine was put together. So what this plan was is a medium-term plan to extend the life of the cyclotron and the service for 5 to 10 years after an upgrade, with the idea of giving the NHS some thinking time and decide what to really do long-term about eye proton therapy. The objectives of the plan are to rejuvenate the team and to modernize the cyclotron. So in terms of the team, in engineering, we recruited several new staff, including myself, and expanded the involvement of the existing LINAC technicians so that they work on cyclotron as well. The same has been done with physics staff, so the medical physicists will rotate through cyclotron if they want to, and also work on Linux, so they're less trapped in the cyclotron and get to do other things as well. The same is true of radiographers. So in terms of our actual upgrades, the cyclotron can look like an extremely complicated magical device with hundreds of thousands of parts, and seems like an impossible task, or at least it did to me. So how do we go about upgrading? This question is my favorite saying. It's how do you eat an elephant? And the answer is one bite at a time, and preferably with your friends to help you and over a long period of time. Sorry for the vegetarians. So how does that work in engineering terms? So in engineering terms, we're going to do systems engineering and project management. So the first thing we did was to examine the cyclotron and divide it into smaller bite-sized subsystems that we can actually understand individually. We then risk assessed each subsystem to see how robust it is, how often it currently fails, does it have a poor history, and if it's just straight up unsafe for patients. And once we had this list, we were able to define another list of what upgrades were possible and prioritize that list based upon the risk and cost benefits analysis. So here's our big list of upgrades. there was 26 that we thought up, and the first thing we did actually is to disregard all the low priority upgrades. So the number 3's got shelved for the time being, and we split the rest amongst the techs and the engineers based on their skills. If you look closely, you'll notice there are no upgrades and changes to the fabric of the actual cyclotron itself. And the reason for this is that the cyclotron itself is made of large chunks of metalwork. It's intrinsically way more robust than the rest of the systems. So we're leaving that alone. There are risks that are involved with leaving it alone, but it fell down the priority list. And we're concentrating on the supporting systems. So we've also split it into further lists. So we have small upgrades and large upgrades. So our smaller upgrades are parts of the machine that are non-safety related. And these are managed according to an in-house ISO 9000 compatible process with a series of gateways and risk assessments at each stage. We have an oversight committee that signs off each stage, and that committee involves our director of physics. So we've got some buy-in and guidance from our senior management too. In terms of major upgrades, these are ones that are safety related and are as such medical devices. And we only have 2, which are our main control system and our dose monitor controller system. And those are managed as full medical devices rather than just our little internal process. So just to give you a flavor of some of the smaller upgrades we've completed so far, we've got a lot of these red power supplies everywhere. So they are our smaller magnet power supplies. We've upgraded vacuum pumps. We've upgraded our beam current measurement systems. We've got video cameras in our vault. So we know if we've got a problem with a leak or a fire ahead of time. And we've upgraded high voltage power supplies. And here's some more upgrades. We've upgraded more power supplies. We've got more diagnostic equipment, such as vacuum leak detection stuff and RF equipment. We've done some less glamorous tasks, such as upgrading our pipework and the building ventilation systems. And we also have some new beam QA devices for measuring bragg peaks and beam profiles. In terms of progress, this is I won't expect you to see this, but it's a list of our milestones, and the ones in green have been completed. So we don't have a lot of white left, and we plan to finish our upgrade later on this year. So it will have been 3 years of upgrade work by the time we finish. In terms of major upgrades, the dose monitor controller upgrade is the system which terminates our proton beam when the prescribed dose is reached. So it's the last line in safety for the patient. This has
1 minute.
Thank you. This is being done as a collaboration with Pyramid Technical Consultants and also Cozy Lab, with Pyramid providing ion chambers and the actual dose control electronics, and Cozy Lab providing code review. And here's some pictures of that system. So there's our new quadrant ion chambers on the left. The center shows what will be the main display. And then we have an equipment cabinet on the right, which is the midway through development. There won't be all those wires in the real thing. And we also have, which may be more of interest for people with older machines, Cozy Lab doing a complete replacement of our control system. So the existing computer control system is a PDP-11 computer, which is the original one as delivered with the machine. It's an absolute miracle it still works, but it does, and it works well. But Cozy Lab are replacing that computer with a state-of-the-art system built on industrial automation platforms. And there's some pictures of the old control system. And the new system that Cozy Lab are building is shown on the screen. Our old control desk is on the top left, and then the rest of the screen is filled with some of the control screens that Cozy Lab are making, and it's a lot prettier and more modern. So by way of conclusion, the cyclotron itself is largely untouched for reasons I went into earlier. And we are doing extensive upgrades to all the ancillary equipment that make it work. All the bits that are actually falling apart. We're working to appropriate quality management systems depending on how big the upgrade is and how safety critical it is. And if anyone wants to know details of any parts of the upgrades, we're happy to share what we can. And yeah, although we're aiming for 10 years of extra running, there are parts which will become an issue in that time. So we will have to continue upgrading things like our RF system is the next one on the list. And we may do things such as servo control, beam steering, and dose rate. And with that, thank you. I'll take any questions.
Thank you very much, Peter. Before we move on to questions and discussion, is the poll open for voting? So
I'm opening it now.
You're opening it now. So just a reminder to everyone to vote in this poll. So I think it should be open now. Yeah, so thank you, Peter, for that excellent talk on a massive undertaking. Any questions? So there's a question from Andrea. How much time did it take to exchange the control system?
So it's a 3-year project. So the first couple of years were spent with Cozy Lab examining what we have and producing a plan and beginning the early stages of their engineering and actual implementation. So downtime is going to be done in 2-week blocks over 6 months. So we're actually using 5 2-week periods to replace the control system. So it certainly isn't quick, but there's a lot of work that the Cozy Lab have done in preparation for it, and that continues. Does that answer
that? There's a comment from Alejandro. No industrial accelerator in the market with this spec or close to, is there not one?
No, I don't think so. I think there will be accelerators with similar beam energies, but they tend to be for producing radioisotopes and for industrial use rather than medical use, and I think that's the issue.
And there's a response from Andrea to Alejandro's comment. We just started a design study. So from Remy, what will be the range of energy that should be produced with this cyclotron upgrades? 62 MeV only.
That might be one for you, actually, Linda.
Well, I think up to 62 MeV. Of course, we downgrade with range shifters on a patient-specific basis. But yeah, up to 62. There's a question from Andre. How do we vote? Is the business plan based on ophthalmic treatment only, or this cyclotron will be used for research too? Question from Remy.
Yeah, it's purely for eye treatment now. We did have some radiobiology research being done on site until recently, but when their lead investigator left the university, they have not continued with that. It's, to be honest, whilst we're upgrading, it's a huge disruption to have people doing research on the machine also. So it's great to have it to ourselves. And I would hope that once we're finished, we could be more open to research later. But it's not part of the plan as I understand it at the moment.
Thank you. Any other questions for Peter? Andre, you should see a window which appears automatically. Could depend on version of Zoom. Is there if you click on polls at the bottom of the screen, does that bring something up?
Linda, I'm afraid it's related to the fact that the co-hosts cannot vote.
Ah, yeah, of course. Okay, moving on. Alejandro's written, can you export what you are producing? What could you clarify on the question, Alejandro? At ClassBridge. Ah, can we? I think that's a question for you, Peter. You're muted.
Yes, my question is if you can reproduce what you are doing in another center.
I think there would be regulatory problems with that. So while we're using everything that we do internally, we are classed as a in-house development under our country's regulations. So we don't have to have CE marking or anything like that. We have to produce documentation to the same kind of standard, but we will not seek CE marking of any of our parts. I think what we could do is share our designs where they're ours. We can't really share anything that Cozy Lab do, but we can share the work that we've done. And I think we would be happy to do that. And you could replicate it.
Thank you very much. Any other questions for the speakers of this session? Or do we want to open up for questions from the symposium? Or do we want to move in? I'm looking at the co-chairs. What would we like to do?
I think finish last minute for voting.
Has everyone had a chance to vote that wishes to vote? How long until we close the voting, Helen?
It's a little bit up to us. I think everyone who's been on, the 80 participants that are still with us probably have had a chance. Should we just move to closing?
Yeah. So I'll end this session, and shall I hand over to you now, Helen?
Sure.
Thank you.
Let's. This appears correct, hopefully. All right, you can see my screen. Please vote. All right, so in closing, I'm Helen Chi, one of the co-chairs also. Thank you to our speakers who represent the leaders and innovators moving our field forward in the advancement and care of our patients with ocular tumors. Thank you for the attendees. It's been a long day and evening for your dedicated time to learn, share in discussion, and exchange ideas and ask good questions to advance our field forward. Thank you to our virtual platform hosts, Jan, Herbeck, Sybil Bohalder, and the rest of the PSI team. And please continue to communicate and collaborate. Hopefully through this, you've been able to see different members in the field internationally who work on areas that you're interested in. And of course, please join us next time in person at PTCOG 62 in Singapore. And congratulations to the best abstract presentation, Corné Haasjes. I apologize if I'm pronouncing you very incorrectly, on optical aberration corrections of fundus photographs for ocular proton therapy planning from LUMC. And lastly, please again, register for PTCOG 62 if you have not yet in Singapore. There will be an ocular subcommittee session on Wednesday, June 12th at 2:45, and all are welcome. Anything else to add from the co-chairs? Otherwise, on behalf of all the planning committee, thank you everyone for your time and participation today.